as smooth. So it's basically reproducible and consistent. So lens after lens, you have that 1, 2, 3 steps, and it's absolutely smooth. Especially because of the also the roughened haptics. You have the sandblasted haptics and the optic edge. So the stability of the lens is also very high. So if you have a toric platform on it, the stability and is so high that the rotation is reduced and your toric outcomes are also much better. So, and you never see the optic and the haptic sticking on each other, or the two haptics sticking, which is so commonly seen. So basically this gives it has a UV blocking system also, and you saw that even with the Impress that the clarity is so good and the rates of PCO are minimal. So in all these patients, especially high myopes, you need crystal clear optics and minimal PCO. So definitely on all these counts, especially the delivery system, definitely I think is absolutely fantastic.
From the stage to the audience, so do we send a message that the time is there when you need to replace all your monofocal practice into modified monofocal, because I mean there is no side effects, and at the max you are giving that patient that kind of intermediate advantage.
Absolutely. I think that is the message that we need to send across, is we need to give our patients the option of that added advantage with no downside to it. So definitely I think that, and today we have this technology and we know that intermediate vision is the need of the hour. So it's not just computer executives, but all of us require intermediate vision, which is so important. So definitely I think this is the message that we need to send across.
So I think Dr. Sri Ganesh is
ready with this next case, and can we have the patient details, please?
Yeah, thank you.
Thank you, ma'am, for such a wonderful surgery, and followed by an even more interactive, interesting discussion. The second live surgery will be performed by Dr. Sri Ganesh on a 70-year-old female with a left eye, grade 3 nucleus sclerosis, and the lens used will be 24 diopter geometric plus toric lens. Over to you, sir.
Everybody, am I audible?
yes.
Yeah, welcome to the OT of Mithidana. So I am operating on the RTO 800, which also has the OCT. So this is a complete 3D system, and you can see the 3D view there. We have used, this is a 70-year-old female. I have already done one eye. The right eye has been implanted with a Hoya geometric toric lens, and for the left eye I am going to implant a Hoya geometric plus toric lens. And as you can see here, we have done the femto with the lens AR. So we have the lens AR, so it has what is known as the intelli axis. So I want you to kind of notice that there are two nubs which are there. So that is the axis in which the lens has to be aligned. So in the capsulotomy itself, you can see the two nubs. Can you see the two nubs here?
Very clear. And
okay. I can even put it in retro illumination. So it's, now you can see it very clearly.
yeah.
So that is introp alignment. You can also use the Callisto. You have the Callisto on the RTO 800. So you can use the Callisto to reconfirm. But actually I go by the intelli axis, because the intelli axis directly gets the astigmatism from the pentacam. And this is transferred to the lens AR, and then it makes the nubs for the placement of the IOL. So now I am going to start Laita Parangama Kannata Bingo. So I like to make my side port, the 1.2 millimeter side port, and then I make a two-step incision. I go along the curvature of the cornea and then parallel to the iris. So I get a 1.7 mm incision. So it's very important. I generally avoid femto because you can see the little bit of waves there. So I like to be nimble rather than clear cornea. When you're using a femto, you have to be completely clear cornea. But I prefer to be nimble because it feels better, astigmatism is less. Now to remove the capsula flap, Laita Parangama Kannata Bingo. I just like to use a forceps because sometimes there can be tissue bridges. If the tissue bridges and you try to kind of
So this
just
lens
going with the
gives you
photoprobe and
excellent
with the viscoelastic
distance
cannula,
and
you
excellent
can have
intermediate vision.
cameras.
So the
Then the
approx near
hydrodissection
rad
you
will
go
be
in with
somewhere
the
around
inside cannula
1.25 to 1.5 diopters.
under the anterior.
And the
You can see
central
posterior
2
tube, you
millimeters
see the
has a
nucleus
micron
rising,
level
decompress.
change in the
And once
curvature
you decompress, you
that
can
can
easily
give
rotate
you
the
excellent
lens.
intermediate vision. So it's basically an advanced monofocal.
I'm going to do a direct
So
shot.
in
I'm
all
using
those
the
patients
sensory
where
lens
a multifocal
and,
cannot be
the
used
parameters are
or there are
700
contraindications
vacuum
or the
flow.
patient is not affording, this
I'm
gives
using
an
the balance
excellent advantage of the monofocal
So use a
with
sharp 1.2
good
mm
intermediate
stopper.
also, and the
This is a
photopic
technical
phenomena
direct
are similar to that of the monofocal.
This is
So
also
that is the best advantage.
You go in
So there is
very,
no reduced contrast sensitivity,
you are
no
very, very
night vision
closely,
issues.
you bring your
At the
shutter
same time, the added
the
advantage
and
of
then split the
a
nucleus
good intermediate along
and
with
rotate,
excellent
very
distance vision.
split,
Definitely near vision we
Again,
will
you
have
can
to supplement with a
rotate
reader,
to, I just aspirate the bubbles.
and you can do a micro monovision and
Split the
probably
nucleus.
use it with the other eye,
And
but
then
we
after that I
tend
go
to
into the torsional
prefer
focal
to keep the target
and then you
emmetropia
can
for
see
the
that you go
patients.
come to the central safe zone, which is in the center of the pupil, and because of the high flow and
case.
vacuum, you don't
Any
have to actually
questions?
move your tip, the pieces come to the tip, and you can, the quadrants are removed. I keep my tip on top of the fragment to prevent it from hitting the endothelium, and you can see I have removed all the quadrants.
Yes, yes, now you can.
Hi.
And then
So
I
wonderful
like
surgery,
to do
and
my
as usual,
irrigation
we
aspiration
saw
with a
plenty
quad
of
wheel
clips,
cannula.
because
So
of
again
the
here my
video transmission,
flow rate is the same,
better,
60 flow rate and 700 vacuum.
perception, and you are getting claps from the venue.
Thank you.
Awareness of
Antibiotic.
Just
pattern,
before we move on to the next case, do we have another presentation?
ಚೆನ್ನಾಗಾಯ್ತು.
radially and tangentially.
The next case,
ಚೆನ್ನಾಗಿದೆ.
what has been your experience with the intermediate? Tell us about the distance and the vision's absolute value. What do you see in
So then I like to do a hydropolis.
implant?
See, the vision for distance is definitely
Clean the
excellent.
capsule
There's no-
with DSS and it will
Yes,
turn
for the
the
intermediate, most of them
cannula.
do well
And
till
you
N10,
can see
N8.
peripherally there's some
And definitely we know that
matter
we
which is there at
are
the
going to
equator.
give them a reader for
all
near.
that comes out.
So the intermediate
So
is
this
much
again
better
reduces
than
the risk
the
of,
previously available
and the chances of
advanced
tissue.
monofocals that we used to
Once you have
have.
a clean bag and a clean capsule,
More cases are needed to
will
get
keep
better
going.
results, more numbers are needed. But as of now, with bilateral implantation, the intermediate visual acuity is somewhere around N10, N8. But if you do a micromonovision, probably you can extend it up to N6, but that needs to be seen with more numbers. The quality of vision, I would stress on.
It's also got a
See,
guard
it's
here.
basically in trifocals, we know that there's always going to be around 10 to 15% of light that's going to be lost.
Actually,
There is going to be a reduced contrast sensitivity, there are going to be photopic phenomena.
lighter paranama.
Whereas in all those patients where you have greater stress on the quality of vision,
Under DSS
plus
and
in
not
all
even
those
with
patients
it.
where trifocals cannot be
And
used,
then you can
or
see that
there are relative contraindications
the
like a
texture
fine
haptic.
VRM or things like that where the trifocal is not
So
going to be the
texture haptic
preferred
is one of the
choice.
feature.
This really
can
works
necessary.
well.
So that
And I think in all those patients where you are
And
anyways
then
going to
you can
use a
just-
monofocal,
Because there is
using
a
an
very
advanced
little
monofocal
elastic
gives
band.
them the added
It comes
extra
out.
advantage.
It is
Yeah, I think
basically DSS
into a single
injection and you can align it along the nubs. You can see the nubs here and the lens is aligned. You can see because the incision is so good, I'm able to see without hydration also you can see the AC is on.
happy patient.
I don't have to hydrate much and I'm able to inject the lens under DSS.
Absolutely.
With
The
this,
patient has a lot of movement, she keeps moving her eyes, so it's a little
when so-called ill behaves, and you do not
disturbing,
get
but
the
anyway, so then you can get to hydrate the
it's still going
sides
to
of the
act as a
incision.
very good monofocal at a distance.
Yeah, it's a more forgiving lens, and I think we should not overpromise these patients too. So you just, and basically you need to talk to the patient regarding what is his functional requirement. So if it's a computer executive who is going to be on his laptop and having intermediate vision requirement, then this definitely gives them an edge. But I think we should not overpromise. Let the patient experience himself, and even the cost margin is really not really very high. So the patient would definitely appreciate the added advantage.
13 mm overall diameter, the contact with the capsular bag is good, and because of the textured haptics, there's a lot of friction, so the lens does not move easily. In fact, you get the lowest rotation with the Hoya toric lenses, and I think the study will be presented by Dr. Sri. You can see that the central 3.2 mm has a diffractive rings there. They are non-apodized rings. I will just put it into. This is oblique illumination. This is the retroillumination. So you can see the 3 mm zone of the non-apodized diffractive
Yes.
optic there, and because it's just 3 mm, beyond that is a refractive. So the night vision is good when the pupil dilates, and when the pupil constricts for reading, then the near vision is good. And this is geometric plus. So there's a differential light distribution between the geometric and the geometric plus. The geometric plus has more
excellent
light
question. Actually, I think Hoya Evolix platform, the multi-cert preloaded technology is one of the smoothest. So what is important is in many of the lens delivery systems, we find that as the dioptric power increases, say for a 30 diopter, the kind of pressure that you need to put in order to deliver the lens is much higher. Whereas with Hoya, we have observed that whether it's a 10 diopter or a 30 diopter, it's as smooth. So it's basically reproducible and consistent. So lens after lens, you have that 1, 2, 3 steps, and it's absolutely smooth. Especially because of the also the roughened haptics. You have the sandblasted haptics and the optic edge. So the stability of the lens is also very high. So if you have a toric platform on it, the stability is so high that the rotation is reduced and your toric outcomes are also much better. So, and you never see the optic and the haptic sticking on each other, or the two haptics sticking, which is so commonly seen. So basically this gives it has a UV blocking system also, and you saw that even with the Impress that the clarity is so good and the rates of PC are minimal. So in all these patients, especially high myopes, you need crystal clear optics and a minimal PCO. So definitely on all these counts, especially the delivery system, definitely I think is
I tried to
absolutely fantastic.
Talk and explain everything.
Modified monofocal because there is no side effects and
Yeah, because I wanted to show the interleaxis. If you do the nucleotomy, then what happens is
Absolutely, I think that is the message that we need to send across is we need to give our patients the option of that added advantage with no downside to it. So definitely I think that, and today we have this technology and we know that intermediate vision is the need of the hour. So it's not just computer executives, but all of us require intermediate vision, which is so important. So definitely I think this is the message that we need to send across.
Almost up to the sleeve, and your chopper also has to be the same level as your phaco tip, same depth as your phaco tip, and then this was a classic horizontal chop or Nagara chop. So you bring it towards your phaco tip and then go laterally so that you split the nucleus. So I was actually doing it quite slowly so you can appreciate the technique of chop. And when you're using chop, then you use very little phaco energy. Actually, we don't find much of a difference between the femto. Even if you do a nucleotomy, you have to use a little bit of fake
Ganesh on
energy
a
to kind of
70-year-old
bury and
female
then separate.
with left eye,
So
grade 3
we don't
nucleus
find that much
sclerosis,
of
and the
difference.
lens used will
But
be
for
24
softer
diopter
cataract,
geometric plus toric lens.
I use
to
what is known
result.
as the visco-chop technique. We have published it. Everybody, nucleotomy, am I audible? Inject viscose into the nucleotomy. Yeah, welcome to the OP of Mr. Dama. So I'm operating on the RTO 800, which also has the CT. So it's very important. I generally avoid femto because you can see that little bit of ooze there. So I like to be nimble rather than clear cornea. When you're using a femto, you have to be completely clear cornea. But I prefer to be nimble because it heals better, astigmatism is less. Now to remove the capsule of light parangama kannata dengu.
Depending on the delta derived from the cornea, how does it go to the machine and how does it plan where the notch is to be set, and how well does it correlate with your image guidance which you already have in place? So does it correlate it with well, or there are at times there is a disagreement?
So basically we have to do a pentacam, and from the pentacam it takes the corneal curvature and the astigmatism, and then that image is transferred to the lens-CR, and from the pentacam you get the astigmatic information, you get the iris image, and also you get the densitometry from the nucleus. So depending upon the densitometry of the nucleus, it automatically sets the energy and the number of cuts. So you can use the pattern. So that is an advantage with the lens-CR because it's completely automated. And because you have these knobs there, the axis alignment is very good, and it is iris registration and not conjunctival blood vessels. With the markerless system, it's the conjunctival blood vessels, the nimble blood vessels, which are taken for orientation of the 0-180, and the axis has to be set on the callisto. Sometimes when you have subconjunctival hemorrhage, or if you have excess blanching of the blood vessels, then you may not get a proper conjunctival image, and sometimes it can be off, but usually it coincides, but I prefer to use this into the axis because I find it's very accurate, and it's the information from the topographer. And post-op also, when you dilate, you can very easily make out whether it's on axis or not, the lens.
Anything else from you, sir? Yeah, please. Just
only I have never used it. Like when you do penta, I would have taken with a normal pupil. But when you're doing surgery, it will be a dilated pupil. Fail to recognize because it's dilated?
No. Usually, yeah, when you do the pentacam, you do it undilated. It takes a iris registration, but it very easily recognizes it. We have not actually had any such case where it has not recognized in fact the recognition is much better than the callisto. Callisto sometimes it might not, you may not get a recognition, you may not get the 0-180 degrees, but with this it's quite robust. We find that it's able to recognize the iris pattern even with dilatation.
I think excellent surgery, Shri, and it is a combination of a premium surgeon, the premium microscope, the premium phaco machine, premium lens hour, and all in all the premium lens. So just a quick word about the lens that you were using. You were talking about that paired approach. So how in your practice actually that has made a difference, because it is all about light distribution vis-a-vis the the earlier the pairing that we were doing was trying to mix and match the different technology or maybe the refractive error.
The advantage of having a differential light distribution is in one eye the distance vision and intermediate the light distribution is more than for near with the geometric, and with the geometric plus the near is more. The intermediate is kind of similar for both the lenses. The distance in the geometric plus is slightly less. So this gives a very balanced approach where with both eyes open the patient has excellent distance, intermediate and near, and because of this differential light distribution you can have a small zone 3.2 mm. So at night when the pupil dilates you have more of the refractive area compared to the diffractive. The pupil dilates to say 5 mm or 6 millimeter, and so the halos, the effect of the halos are not as much as a regular full diffractive IOL with a normal say 50-50 distribution or a trifocal with distance intermediate and near, which is the same in both eyes.
actually, at least I've experienced it, this differential light distribution with a plus coming in the second eye in particular, or the first eye as the case may be, has actually helped a lot of people with low light reading. So normally when we implant trifocals, we actually ask them to increase their lighting in the ambience so that they can see the readable better. But with the spared approach and the 46% of the light coming to near with a plus, the low light reading is where actually it has helped the patient.
And it has a 3.5 ad for near and a 1.75 for intermediate. The ad does not actually differ between the eyes. It's just the light distribution, which is basically adjusted by adjusting the steps, diffractive steps. And with that, I think they got a very nice balance and very good patient satisfaction. So we have been using quite a few of the lenses. We have nearly put in about 50 of these lenses right now. And we find that the patient satisfaction is quite good. Even the complaints of night dysphotopsia are less when we compare to the other trifocal lenses.
Thank you so much. We'll let you go
Thank
briefly
you.
to come and join us. I'll be ready with the next case and I think we can proceed.
Thank you, Dr. Sri Ganesh, for such a detailed explanation intraoperatively and followed by an even more interestingly informative discussion. It's always a visual treat to observe Dr. Sri Ganesh operate. Before we move on to the third life surgery, I would like to ask the audience if the glasses are working fine. In case of any issues, you can reach out to the nearest representative and ask for a replacement for the same. The third surgery will be performed by Dr. Savio sir on a 59-year-old male, right eye, grade 2 nuclear sclerosis, cortical cataract plus PSC, and the lens used will be 18 plus Hoya Vivinex toric. Over to you, sir.
A very good morning, everyone. I hope I'm audible and the feed is clear. So this patient which I'm operating is basically a plus 18 diopters, a bit of a myope, and also on tamsulosin because he has BPH. So I'm going with the regular conventional surgery. I know you'll have seen beautiful surgery seen by Dr. Anaga and Dr. Sri Ganesh, and I'll be making my regular surgeries with, I use my side port first. And what do I really notice is that when we switch over to torics, it should be one of the first refractive surgeries that any surgeon can do without any additional equipment. So I just put in a little bit of intracameral xylocaine. Okay, viscoelastic. Sir, like की तरफ देखो, 3 light नजर आ रहा है. You can see there is amount of nuclear sclerosis and also there is amount of cortical cataract over there, just one part, and it's actually differentiated from the epinucleus. You have a large, deep AC here, and you can see this gentle ooze. This is what I really like about making wounds. And yes, I've been doing a regular rexis with my 26 gauge needle over here. So yes, femtorexis are really beautiful. You can never replicate them. But what I will try to say is that we can all start off, and because of the stability offered by most of these femtorexis, we can go ahead and do a normal rexis. In a high myo, be a little careful. Rexis can sometimes tend to run out. Little more visco. हाँ गेरी. So like की तरफ देखो, 3 light नजर आ रहे हैं, very good. Since we are using the Vivinex platform for toric IOLs and the texture haptics give additional support. So earlier we used to go in for a good overlap of the rexis, but you can see that sometimes your rexis can be larger and that's normal. Don't worry, especially if you have very dense cataracts, we all love making a larger rexis. But you can go ahead and put toric IOLs in even in these patients. So I to use a biplanar incision. हाँ गेरी. So light नोड़ी please. Light नोड़ी. 3 light हाँ. 3 light की तरफ देखते रहना है. Good. There and the dip inside. So gentle depression. Do the hydro dissection. You can do the rotation at the same time. And yeah. Always make sure that you've got a good dissection. So I'll be using the Centurion and great light nodi, like की तरफ देखते रहना है. I've exposed my tip a bit more because being a high myope, the anterior chamber is much more deeper. There, you get the first chop. See that the separation has gone true and true. Then you go in for the second chop. Again, make sure that the separation goes true and true. Sometimes you'll have these adhesions which are going on, but it's fine if it's in the periphery because that's just the epinuclear adhesions and they will break off. So there we got pieces you want, you can go ahead and even break it into further smaller pieces and that's fine. See that the separations are complete and that is the key. Once you go into the quadrant movement, the nozzle just takes over and the pieces come to you. So that's very, very gratifying that you just be in the center, safe zone, being a high myope. Most of the pieces are quite away from the endothelium. Eat one piece at a time and yeah. The only thing you need to be careful of, especially in patients with BPH, is that they can sometimes, the iris can start coming to your wound and there'll be a lot of fluctuations. Light nodi, like it taraf dekhte rehna sir. So I use the bimanual irrigation aspiration, and one of the reasons why I love the bimanual irrigation aspiration, especially if you're putting toric IOLs, is you can rotate your lenses. If in the case the pupil becomes small, you can use the irrigation to retract. And the other thing is that you can maneuver the lens much, much better with a bimanual. It's also easier for the subincisional cortex to be removed. Switch over hands. I always tell my students, one after you finish the 180 quadrant, switch over to the other side, and that's important. Don't try to tip too much because then you may end up catching the bag. You sometimes get these fibers which are stuck over there, and as sir rightly said, you can go ahead and just do a good hydro polish. And these fibers readily come out and that leaves a much cleaner bag for you to place your lens. The entire thing appears so much clearer. So are we using the Vivnex toric? This is based on the Vivnex platform, and you can see here, great. You have the Callisto markerless system, which will be guiding me for the axis. So it's at 81 degrees. So this is where I said that you can go in with the bimanual and you can just rotate your lens, place it in the axis you want. You can even go ahead and, rotate it, tilt the lens, especially if you want to remove the cortex from anywhere stuck or put viscoelastic. So you can see yes, some amount of the blood has oozed, which was there. So I just washed that out. Great. Once my lens is in the axis, that's the time I just tip it down and place the haptic in the bag. Since being a high myope, you can see it's really deep. Just wash off all the viscoelastic. And the texture haptics, that is something which is really beautiful. Also, it has mild serrations along the edge of the haptic. And if you see that, the stability of the lens is mainly because of these two factors. Yes, the optic is smooth, the square edge all add on to it. But once you have a really good grip of the haptic by the edge of the bag, that really helps out. So I would say that everybody should start off using toric lenses as their first refractive surgery lens, because that's really easy to use. In case there's any additional viscoelastic, you can just wash it off while doing your hydro polish. Main thing is what I like to do is just see that the lens is placed in the axis. Now you can see there's a slight, tell the patient to look in the light, look at the Purkinje image. Once you hydrate, sir light ki taraf dekhte rehna. It's very important. You can do the final adjustment from the side put. And sir light ki taraf dekhte rehna. Teen light dikhai de raha hai aapko? Dikh raha hai teen light. So sometimes with the Callisto, as sir said, you may have a little bit overlay, but it's important to see that the marks of your lens are parallel to the three lines. So even if they are not coinciding, if they are parallel to the three lines, you know your axis is bang on. And there you can see it's well in the axis, or you need to see that the Purkinje image of the cornea and the lens is well in place, and the toric lenses you can see here it's parallel. And that's about it. Leave the eye a little bit soft. And yes. So this is a toric lens, and as I said, the injector is really beautiful. Luckily, I got away without putting any adrenaline. Usually I prefer adrenaline in patients who have light nerdy, like taraf dekhte rehna. So you can see here, you can do a check once you remove the speculum, the axis is bang on. And there you can see. So this is the beauty about this lens. The stability is really great, and these lenses don't move anywhere. So,
Congratulations, Dr. Savio, for that wonderful case. And I think your patients actually work. So 3 quick teaching pearls that you brought out, the way the rexis was running off and the way you used in viscoelastic and managed in high myopes, I think that's a very important teaching pearl for all of us here. Viscoelastic at the right place is very important to prevent that runoff. Secondly, that vertical chop in cases, specifically if you have high myopes and long axial lens. So I think you have to be very, very careful, because that handpiece has actually to go in vertical to do that chop. And thirdly, that check in cases of toric, once you remove the speculum, I think that is very, very important to prevent that and to recheck that rotation at the last minute. So do you keep these patients waiting, and do you do a slit lamp examination after an hour or so in your toric practice?
So usually, if you check on table after removing the speculum, these lenses really don't move. If you have removed the viscoelastic and you have placed the lens in the bag, it doesn't move at all. So usually we don't wait, make the patient wait and do a recheck, because the pupils also start coming down. The check is done mainly the next day and after a week. After a week, if it has to be rotated, then we rotate it at 1 week. But so far, we have done quite a few, more than 200-300 surgeries with this lens, and not one of them also have required any rotation. So that is something which is very promising.
I'd be interested to know the fluidics profile you set in your machine, Savio, because you said that it's a myopic patient, but we hardly saw any bleeding of the pupil. So did you manage that with the fluidics setting, or?
Yes. So what I did was I kept my IOP really low, just about 25. And when you keep the IOP low, the fluctuations that occur, especially once you go below the pupillary diaphragm and the pupil doesn't, come up, and the bag also keeps inflated at all times. Most of these high myopes, if you increase the IOP more, they'll start wincing in pain because of the bag which is stretched, and the stretch on the zonules and in turn on the ciliary processes. So keeping a low IOP in such patients really works wonders. And also the patient is much more comfortable during the surgery.
And that's about the IOP, but what about the other differentials, the flow rate, the vacuum, the irrigation factor, and the vacuum rise? Was that all normal, or?
I usually keep my settings about 700 for the vacuum, and the flow rate and the power is 80, which is torsional. And for the quadrant removal and longitudinal, I don't use any torsional power while doing my chops. And the flow rate is around 45-50.
Yeah. We have a question from the audience, Savio.
Yes.
Yes, sir. I just wanted to ask you about the role of CTR in such high myopes requiring toric IOL. Do you routinely use it, or there's no role as
No,
such?
you don't need to use a CTR for every case. One of the things is, when the moment you implant the lens, you see the stability. I would say a role of CTR comes when, if you get a rotation once, you can re-rotate after 7 days, within 7 days, and then if you get a rotation again, that's the time you should go in for a CTR, because the CTR will collapse the bag, make it more planar, and it will fix the haptics better. So not all high myope cases you need to put in a CTR. Yes, this is a good 13 mm lens, so unless you have a really large bag where you can see the lens is unstable, even while placing the lens, you notice a lot of rotation occurring, that's the time, yes, you can plan it for a CTR, but otherwise not required.
Thank you.
Check. Yeah. All right, so
Thank you so much.
that concludes live surgery session 1. You can see how intense and engrossing these are, because you can actually hear the surgeon modulating his breath while he's operating. So, oh, he could hear that? Okay. All right. So now the next event, the next speech can be a function in itself because it shall be delivered by somebody who is one of the most respected, one of the most well-known voices in cataract and refractive surgery, a doyen in the field, and I'm sure many in this auditorium are inspired by him, but there's one in particular who is best placed to introduce Dr. Suhas Haldipurkar. Yeah, you can applaud to that. So I now invite my teacher, Dr. Sri Ganesh sir, to speak about the impact of his teacher, Dr. Suhas sir.
Well, what can I say about one of the most popular teachers in ophthalmology from, I would say, 3+ decades. I remember I first met Dr. Suhas Haldipurkar in 1995. I started my practice in 1994. 1995, I started doing phaco. I just started off doing phaco. I first watched Dr. Madhivanan, and in our days there were no mobile phones, there was no YouTube, there was no internet. So we used to read, of course, there was only Barry Siebel and Paul Koch, only 2 books on phaco. And then we used to go and try to observe surgeons because there were very few surgeons doing good phaco, experts. Dr. Suhas was very well known. You could count on your fingers the number of surgeons doing phaco in India who were really good, whom you wanted to go and learn from. So first I went and observed Dr. Madhivanan and started doing divide and conquer. And then somebody told me, oh, Dr. Suhas is doing a technique called stop and chop, which is, faster and all that. So I was traveling to Mumbai with my wife. I decided I'll go to Panvel, and somehow I was able to fix up so that I could go and see his OT. So I traveled from Mumbai to Panvel, and then I was fortunate enough to observe his surgeries, and then we just had a talk. I said, yeah, and I was surprised that he spoke in Kannada, which was a pleasant surprise. And then one of his fellows, he finished his list, and one of his fellows, I believe it was Sanjay, I remember, he started doing one of the charity cases. And then Dr. Suhas went out and he had some discussions and all, and came back, and this chap was still struggling to sculpt. Then he said, Bengaluru phaco heng ಮಾಡ್ತಾರೆ ನೋಡೋಣ, you scrub up and try to finish the case. I was in for a shock because I didn't expect to operate, but I scrubbed up, and then I did that case and we finished. And then I was supposed to leave back to Mumbai, and he said, what are you doing? Do you have any other program? I said, nothing, I have to go back to Mumbai, my wife is there. Then he said, why don't you stay Saturday night, let's have dinner. He said, but sir, room, there's no night dress, nothing, no toothbrush. He said, no, I'll give you a pair of pyjamas and then a toothbrush, and we have a nice bed in the hospital, you can stay there, we'll have dinner. So I stayed back and had a nice dinner and some wine with him, and that's how the fellowship and the inspiration started. And he said, I'll drop you tomorrow. Anyway, I have to go to Mumbai. I have a CME, I have to give a talk, so I'll drop you there. No problem. And so next day morning we went, and on the way we stopped at a Udupi hotel, and we were having idli and dosa, and then I still remember the conversation. He said, see, now, people are doing topical phaco, so you have to get into that next, topical phaco chop, and foldable lenses and all that. So it's very important to be updated with technology, and that's how your practice can improve. And those words still ring in my ears, and I took that advice very seriously. And then, of course, I moved on to phaco chop, topical phaco, foldables, and that's how my career progressed. So whether you have a mentor for a day or for a year or 10 years, you should be ever grateful to them and recognize that, because that inspiration, that time you spend with that person can change your life. And I'm very thankful to Dr. Suhas Haldipurkar, who has been my inspiration and an inspiration to a lot of surgeons at that time. And I think we'll be ever grateful to him, and I thank him very much. And I really value our association. It's been nearly 30 years now, 28 years, and whenever we still meet in conferences, we actually discuss, have a nice time, have dinner, so it's so nice. Thank you so much.
Thank you, Dr. Sri Ganesh. It actually felt like we lived through the journey of yours with Dr. Suhas. Thank you for walking us down the memory lane. Now I would like to invite Dr. Sri Ganesh on stage to felicitate Dr. Suhas, not only for gracing us today, but also for a lifetime of contributions in ophthalmology. Wow, what a moment. Like, I'm literally falling short of words. I would now like to invite, I don't think he needs an introduction, the most inspiring Dr. Suhas to deliver his keynote lecture, The Lens Story. Sir, the stage is all yours.
फाइनली किसी ने तो टोपी पहना है मुझे. Dear, my very dear friend Sri Ganesh, indeed an honor, and it's indeed a privilege to be here. This place is great. In a way, I'm indebted to him because my daughter, who is an excellent surgeon, she was trained here by Dr. Sri Ganesh, for which we'll always remain indebted to you. Well, I start my keynote with a question. Is there anybody in this hall who has started his practice without implant being part of it, part of his life or ophthalmic life? Have you? Well, so that's a very small group, because the year is around 82, 83 when the implantation started. But believe me, it's a great story. It's a very interesting story, and how it all began. And since implant is going to be part of a professional life all the time, I think it is necessary that we delve into it. Like they say, those who do not learn from history are doomed to repeat it. See, unless we know where it all started from, it will not really be able to appreciate and enjoy all that journey that we are going through. Contrary to what we think as 1949 and the Second World War, the attempt was made much before, but we know that that attempt was a failure because we are still not ready for it. But what it did was that thought that was planted in 1795, it took 150 years to germinate, and then the story shifts to London, and the character is Dr. Harold Ridley. Harold Ridley at that time, a junior doctor, but by no means, he was in fact a very serious research scientist who had done a lot of work on onchocerciasis when he was posted in Africa as a military person. And he has famously said it. IOL represents a cure for a disease called aphakia. And it was his passion. He was obsessed to find a perfect cure for aphakia. The often told story is about the Second World War and the Royal Air Force cockpit injuries and all that. But the concept of putting a plastic piece in the eye and for it to function for rest of life was a thought that was quite alien at that time. But it was a very major thought because it led to all the future implants and transplants that came into different fields of medicine. So in that way, that indeed was a very, very groundbreaking thought that that Dr. Harold Ridley came with. And for all of us as ophthalmologists, it's the 29th November 1949, which is in fact the most significant date, a landmark event. Now just imagine, this landmark event was shrouded in secrecy and to avoid fierce criticism. Normally, such an event would happen in the most premium of the institutes. And at that time in London, Moorfield was the institute where this thing should have happened. But it never happened there. It happened in St. Thomas Hospital and in a side theatre as the 7th case. And contrary to what we all believe, it was not an implant, primary implant. It was a second implant. That patient, like at that time, he decided it will be done in 2 stages. The patient would be operated for cataract. When the eye is quiet, he would be taken for a second implant. And that is how it was born. But now imagine, put yourself in that situation when the world is all, full of criticism, and somehow you want to get good result out of this case. So what kind of a night Harold Ridley must have spent, and next day he gets up to one more shock. The post-op result is -18 by -7. Now that's a refractive surprise. So as anybody today, the first thought that will come to our mind, then probably what must have happened after he did his IOL exchange. Believe me, my friends, that the concept of IOL exchange was never born. And we didn't have the skills to do an IOL exchange. So that patient lived with that refractive error all his life. And now, the entire team and the optical engineers went into calculations. They said, how can we kind of improve it? And the second case was kept at Moorfield. And after 2 or 3 months, and that time again, the refractive surprise was -6. Now, this is what it is, when such things happen and when your seniors, your peer is just waiting to pounce upon you and you're in for public criticism, what you need is a mind of great men. The final proof of greatness lies in being able to endure criticism without resentment, because this guy, his passion and his obsession to find the cure for aphakia was so huge that he just continued to work. In fact, he kept refining it. And 2 years later, in one of the prestigious conferences in London, he presented his results and took along like prized bulls, 2 of his patients whose vision was 6/9 and 6/12. But still, it didn't stop his seniors from criticizing him, and that included even Duke Elder. So he had to really, really go through all that, but he just continued. And I was also surprised when I was doing research, he continued to put almost 1,000 such implants with reasonably decent results. But what happened? he had almost 15% complications and many eyes were lost. But that didn't really give bad name. The bad name came because even other surgeons started doing it and everyone wanted to have his own design. And that's when, the lens got absolute bad name, and it took a lot of time. And now when you look back, you think probably that was necessary because we still had to learn how the eye behaves with such different shape, different size plastic in the eye. And then, that was a very, traumatizing period because the development in the lens technology literally came to a halt. And when you look at historically, the lenses that developed have been classified into 6 generations, and we are now concerned with the 5th and 6th generation. Well, those are the lenses that we came into ophthalmology with, and we continue to use it. Now, this is an important slide because it tells us that all kinds of experimentations and permutations, combinations that are tried, and finally we are today. And today what we have is something we have just seen also. In fact, it's also very interesting to know how they must have sterilized those lenses. It seems when Ridley wanted to implant his lens, he was wondering, how am I going to make it sterile? So he rushed to his pharmacist, and pharmacist said, well, the only thing you can do is use cetrimide 1% and just dip it in, and then rinse it just before using it. And he used it, but then later it was found that even that cetrimide would have some micro amount left on the lens, and because of which the lens was patient would get a lot of inflammation after the surgery. And then came the method which all of us, at least I have used, the sodium hydroxide 10%. You have to keep it immersed in that solution for some time, and then neutralize that with sodium bicarbonate and use it. Now, this was used almost till 78, 79. My mentor, Dr. S.M. Sate, in 1979, when I was working with him, he was trying out these lenses from Shansha, and it was my job to do all this sterilizing process for him. But I tell you, I've seen those post-op results where the lens would be totally coated with pigments. It was a severe reaction. And today, when you want, when you just want a lens, the runner would come and just open it for you. But it was so difficult then. And ETO came as late as 1978. It is said by Victor Hugo, nothing is more powerful than an idea whose time has come. We all know that in 1967, Charles Kellman came out with his phaco. Even he had lots of failures to begin with. And the 70s was the opportune time for phaco technology, and it was also good for a kind of trying to use one technology along with the other, and that is how phaco really came into being in the 70s. And when phaco came into existence in a little more popular way, what happened was it revived the prospects of lens technology. So this is an example of how the two technologies, different technologies, can help each other develop, modify, and really make medical world richer. But we have to take into consideration what were those significant changes in cataract surgery that really propelled it. It was a gradual shift of a cataract surgery from an open chamber to a closed chamber technique, and because of phaco, the wound size started coming down. And that's when the most significant of a solution, that is viscoelastic, was introduced. And with that, the cataract surgery and the implantation techniques never really looked back. But it is very important for today's phaco surgeons to realize that the earlier phaco pioneers had to use phaco in these absolutely inhospitable conditions. There was no self-sealing wound. There was no rhexis, there was no linear control on the energy delivery, there was no energy modulation on the phaco, there was no surge control, and even the venting system was not good. Now, isn't it very scary to realize that phaco was still practiced in those? And here we should remember that Dr. Charles Kellman, Robert Sinsky, and Richard Kras, these were the early surgeons. in spite of, opposition and criticism, they continue to teach. In fact, there's a story. There was a Hollywood actor called Robert Young. He was a patient of Richard Cross. And there was a time when FDA decided to ban phaco and stop lens implantation. And that is when this fellow had to be literally, sent. He went to meet senators. And there's a big story where FDA decided to withdraw it. And if it was not for such initial help from different quarters, today probably we wouldn't be standing here talking about phaco. We all know that cataract surgery today is the most performed and most perfected of procedures among all the surgical procedures in the world, in the medical world. And so is the lens, because we have seen what all has changed of lens, literally everything beyond recognition. But when I look back, at least I remember these three instances where, a product came and we were not still ready technically or otherwise. Like Ridge, I clearly remember 3M came out with a diffractive lens, diffractive multifocal, I'm sure you have. It was a PMMA lens, excellent lens, but it didn't really do well because as a cataract surgeon, we were still not ready for it. We didn't have the concept of astigmatism. Our wound closures were not so good. And the fibrosis that PMMA lenses caused was, unexpected, meaning you couldn't really predict, and because of which this lens had to go. And the second lens was accommodative lens for human optics. Now just imagine, you have to come in the right time, you have to be poised in the right, you have to be positioned properly. Now that was an era when multifocal lens was coming up, and this accommodative lens came, and it wanted to position itself against a multifocal, and it failed. And at that time, the extended depth of focus concept was not there. Like, sometimes I feel, today if the accommodative lens had come and positioned itself against an EDOF lens, probably it would do well, because all those lenses were doing extremely well for intermediate distance, but they were positioned for near vision. See, these are the things. Then another was the very famous star, plate haptic lens. They were the first ones to come with toric, although they had limited range. It was a good lens, but the lens rotational stability was never really studied, and this lens literally bombed, and they had to take it out. So there are several instances where the technology was there, but technique was not really appropriate at that moment. So let's come back to what has changed in the lens. I mean, literally everything. The design has changed, the shape has changed, the size, surface curvature, haptic design, literally every, and in fact, all these changes have happened, and we have literally gone over it for almost sessions together. Sometimes a particular design changes, and for next 6 months we keep discussing about it, and different companies come out with their own version of that particular change, and that is how we kept growing. So it's very interesting for most of us that all these things we have lived, we have seen these things happening, and the biggest change that happened was in the lens optic, which is still a work in progress. Even today, when Vivinex comes with Geometric and Geometric Plus, we know that, well, the final answer is still not set. We are still working on it. But over the years, what has happened is different companies have kind of consolidated different features into that design, and it's become an established platform. The first one that I remember was a Technics platform. It came out, some of the features which are so very excellent, and then we knew, okay, well, this is a great platform. And then any lens that would come on that, I would use. And then, of course, there was Acrisoft, and now it is Clarion. Now, these are all established platforms. And similarly, in the last few years, the Vivinex preloaded platform has come. And I'm sure those of you who have used preloaded would vouch by it. But there's no other lens which has that beautiful, smooth, preloading system. And to back it, that lens came with its own definitive features. It has that active oxygen posterior surface treatment, the ozone treatment, because of which the PCO rates are so low. It's outstanding rotational rapidity because of its, roughening of its haptic. and no calcification. These are all different features that have come in the Vivinex, and today we are all talking about Vivinex, the Geometric and Geometric Plus. My speaker after me is going to speak about it much in detail. But the beauty of this is, with 3.5 and 1.75 add remaining same in both the lenses, the light distribution has changed so as to give you, literally in all the situations, we want you to, or the lens wants us to be happy with satisfied vision. So all this is happening, and then I finally come to this particular fact we should never forget. Today, when I do a good surgery and come out of the theater, or when I see my patient post-op, final follow-up, he comes, he's very happy, and he tries to touch our feet. Remember, he's touching the feet of these great men, and we are standing on their shoulders to be, acknowledged for that. So with this, I thank you all. It was a wonderful opportunity for me to share, because to me it's very personal, because I started my practice in 81. For 3 years there were no lenses, so it was without lens, and then the rest of my journey has been along with this. So this story is like my own story. Thank you so much.
Can we have a huge round of applause for Dr. Suhasa, please?
In fact, this is the month. 29th of November was when Harold Ridley put in the lens. So in 3 days it's going to be the 74th anniversary. And next year, the Ridley Foundation is having a celebration in UK for the 75th anniversary of the first intraocular lens implant. So it's going to be a huge celebration. And yes, I'm planning to go there. I'm part of the IIIC. The IIIC is an international intraocular club which was founded by Harold Ridley for people with innovative ideas who can discuss. Because in his time, he was actually shunned in the UK, and he had to go to US and make his presentations, because his seniors like Duke Elder, they were totally opposed to intraocular lens. In fact, they banned him from the society. And his story again has a lot of obstacles before he was, in fact, he was not even knighted. It's only after Harold Ridley passed away that he was knighted. After Duke Elder passed away. After Duke Elder passed away, yes, then he got his knighthood for his invention of the intraocular lens. So always, when you come up with an idea, it's a long journey, it's a tough journey, there's a lot of opposition, but again, innovation is the way to go, and if you persist, you will be successful. If you think you're going to be successful, you will be successful.
So we shall now depart for a short tea break. Please be back here in about 15 minutes time, and make sure you do not take your 3D glasses out of this auditorium. Either leave it on your seat or please hand it back to the coordinators. You can collect it back. Yes, we have a coordinator at the entrance. Please hand it to them.
actual measurement, I would say. Yeah.
Yeah, I think we are running behind time, so we'll go on to the live surgery session. If the OT is ready, I think we can start with the first surgeon. I think you can all put on your 3D glasses.
Let us delve in the sea of the live surgery again. From the OT, Dr. Rohit Om Prakash, Dr. Sonu Goel, and Dr. Anurag Mishra will be joining us. The first case will be performed by Dr. Anurag Mishra on a 62-year male, left eye NO3 P2C2, and the lens used will be 23.5 Hoya Geometric Plus.
Dr. Anurag, you're on, so you can speak and then.
Like 30, it's a 62-year-old gentleman with a grade 2 cataract, and what we have planned for him is a geometric plus 24.5 non-toric. So this is the way I make my incisions, the side port and the main put together, and then at 90. So the first side port is placed a little oblique, and the second would be along 90. And then I would instill a small quantity of preservative-free lignocaine into the eye just to make the whole procedure pain-free. Some amount of HPMC as a sole viscoelastic that would be used intracamerally, and then straight away it would go to capillaries. I did check on the angles, the alpha and the kappa, both were in the 0.3 range, so that makes it perfect for this particular implant to go in this eye. And we have already had a very strong opening statement coming from Anaga, and a discussion that followed later on with regards to the pair approach and the light distribution. We did talk about it early in the morning. So technically, if you go to the design front, the only thing T25, so please keep your chin up a little bit. Yeah, that's it. No. So if they go for a bang on 50, 25, 25 distribution of light, but in here it's a little different, just to give us that extra bit of comfort, cushion, deciding which IOL to focus on which distance. So just to look at the parameters that I would be using, I am using the Centurion vision system as the machine, but the parameters, the fluidics are extremely low as are normal with my procedures. I keep an IOP of 20. If the video camera can just focus on the screen. So the IOP is kept at 20, and the flow rate is at 23, and the vacuum's set at 450. I do tend to keep the IP switched on even for chopping, because that gives me a selective burst of longitudinal phaco energy whenever that's needed. Of course, this is a very soft cataract, so I would hardly need that, but I'm just saying generally, when you encounter a harder nucleus, that just gives me an extra longitudinal burst to go into the deeper substance of the nucleus. This is a very soft cataract, so you can choose how much of power to use. Mostly these cataracts can be chopped with the help of vacuum and what's called as a mechanical chopping. Just keep the probe there and separate with the second instrument to separate the pieces out. We go to the quad mode, the IOP stays at 20, the aspiration flow rate increases a wee bit to, sir, please, don't move your head around. Thank you. So the IOP stays at 20, the flow rate just goes up a little bit to 26 and it stays there. The vacuum's around 450 to 500 and that's enough for us. So if you have access to machines nowadays which give you excellent fluidics comfort, be it with active fluidics, without active fluidics, what you can significantly come down on is the energy front. So you can use less amount of phaco energy, in fact less amount of fluid as well, and then do off the procedure keeping all the tissues in their physiological state and not causing much of fluidics or energetic stress onto the endothelium or the other sensitive structures that are around. So all done, nucleus, epinucleus, cortex in one go, and we have hardly used. So I'm very firm believer, Dr. Sri Ganesh was emphasizing on this hydro polish of the posterior capsule in the morning. I'm also a very firm believer of that. So these stubborn little cortical fibers which stick to the posterior capsule, best removed with creating a BSS wave just before you make the bag ready for the IR implantation. So we just do that, and sir, please don't move your hand around. Thank you. I believe this is a much softer technique than the capsular polish mode. Now we go straight into the IR implant. The IR has been made ready. No, I don't need the IA anymore. I've done all that. So this is the Geometric Plus 24.5 as we mentioned, non-toric. And I would implant it on the cover of BSS. So this is the 23 gauge irrigation cannula that I use for the purpose. And just switch off the irrigation for a while till the teardrop backcut goes in. The cartridge can go right into the bag and deliver it there. Once the lens is out, most of it, you can just pronate your hand a little bit. Take the trailing half, take the curve and leave it there so that the IOL straight away goes into the bag and opens there. You don't have to use the second instrument to place it. Just a little bit of aspiration needed. We have one small chunk of epinuclear plate remaining at the side port incision. Just remove that. Otherwise, we wouldn't have had to use that as well. So the IOL is in place, perfectly centered, and with this kind of handling of the wound, we saw that with Dr. Sri Ganesh also, you don't have to actually hydrate the incisions at all. You don't have to do any stromal hydration, just do one height port, just a little bit of hydro of the stroma, and the AC is formed right up to your expectations. That's the end of that. Thank you so much for watching. I'm ready to take up questions if there are any.
Wonderful surgery, sir. I think it's, I mean, you were so calm and the hands were so steady. And hats off for doing cortical removal with the phaco probe itself. It's extremely difficult, but you have shown it. It's a very challenging, very advanced technique. So very nicely done, sir. Fantastic. Yeah.
Yeah, but at the same time, perhaps we all agree, Naren, that this should be performed or attempted after you've completed.
Exactly. Very advanced it is. Extremely difficult. It's not easy.
I think for beginners, especially, it's better to avoid doing this because the phaco tip is quite sharp, and if you have some fluctuation in the chamber, then there's a higher risk of ending up with a PC rent.
I cannot call it. Yes, sir. Sorry, sir.
So with IA, especially if you're using coaxial IA, it's very fast. So you don't save much on time. So I've done this before, but I don't see the advantage, because anyways you have to go in with your IA if you want to kind of clean up that little bit of strands which are there in the periphery.
Yeah, I don't know about you, sir, but it does save a little bit of time for me because perhaps I'm slower when it comes to removing the cortex with the IA cannula. But what you're saying is right, we don't perhaps save much on that. It's just another way of doing things. I mean, I must say that it doesn't work all the time. Sometimes you have to stop midway. You know that the cortex is not coming out, it's not loose enough, it's not coming out to your expectations, and you have to stop. Don't chase after it. However, if I can call that a tip at all, the tip is with the low fluidics, just to avoid the anterior chamber fluctuations and accidentally catching the posterior capsule, what you can do is you can rest on the aspiration flow rate to do the job for you. So don't increase on vacuum, don't go to foot switch position 3, which is a very natural flow of the foot on the foot pedal. So just stay on the AFR and let the AFR bring out the cortex. If you've done the hydro well, most of the time, perhaps if not all, you would be able to pull it off. But what you're saying is absolutely right. There's no dogma in that. The moment you think it is not coming out to in the way you like it to, then just stop and change hands and change the eyepiece.
Because that is very critical to decide when you stop going after that. If there's sticky cortex and you keep persisting and you are in the periphery, and periphery is not a safe zone for the phaco-tip, because what I teach is always stay in the center, and this is what I was saying. And I like to use a higher flow rate so that all the pieces come to the phaco-tip rather than moving the phaco-tip in the eye. Because when you go to the periphery, it's shallower there. And a little bit of fluctuation also, the PC comes up. The central area, you have more space there. But again, it's the decision as to when you need to back off. Because sometimes, if your cortical cleavage hydrodissection is not very good, then you have sticky cortex which there's no occlusion. So basically it has to, with the flow, it has to come out. So sometimes if it's sticky, it doesn't come out, then you go a little more to the periphery because you're tempted to kind of remove it, and then if you have a little bit of fluctuation, that's when you end up with a problem. So if you have enough experience and then doing this, and you're sure of your chamber stability, then probably yes, but not for beginners, definitely not for beginners.
Yeah, each to its own is the message. So,
not for beginners.
Right. Thank you so much for the opportunity once again. So I would just briefly come to the hall to meet you, and then I have to push off to the airport because my departure is drawing closer. Thank you so much for the opportunity and the honor. Thank you.
Thank you. A wonderful surgery. Congratulations again.
Thank you.
Thank you, Dr. Anurag, for such an exemplary surgical demonstration, followed by an informative, interactive discussion with the panelists. The second live surgery will be performed by Dr. Rohitam Prakash. I'm extremely sorry, there's a little change. The second live surgery will be performed by Dr. Sonu Goyal on a 73-year-old male, left eye NS2 early PSC, and the lens used will be 20 plus 25 diopter T2 Hoya Vivinex toric.
Yeah. Can you hear me? Am I audible? Hello, can you? Yeah, we can hear you. Dr. Rohit, we can hear you. First of all, I would like to thank Dr. Sri Ganesh for giving me this opportunity to come back with such better surgeons around and calling me over. It's a privilege all the way. And I can tell you it is one of the best facility. I am not one who, appreciates easily, but this is one of the best facility you will ever come across. So I have been assigned to use the impressed intraocular lens. The patient has hardly 0.25 astigmatism. My preferred site of incision is the, can you make it totally retro? My preferred site of incision, can you increase the illumination? My preferred site of incision is the temporal site of incision. Why so? Because it gives me better access. There is no brow in between. There is better red reflex, and it is astigmatic neutral.
and I don't use bibevel keratome. I use a bevel up because that gives me control, and my site of incision is right at the limbus because that provides me with a situation wherein there is faster healing and stronger healing. Next I introduce is the visco. Yeah. Intracameral is being injected. Now I inject visco. I will be using hydroxymethyl cellulose, going in, creating a situation where the chamber is adequately deep, side port instrument. The side port instrument which I use is a calibrated side port instrument. This is a 25 gauge needle which has calibration of which has sizing of 500 microns. So this 500 microns gives me the ability to calibrate my side port instrument with incision so that there is less amount of efflux of fluid to the side port. Capsulorhexis, I try to phase out with the capsulorhexis forceps. An initial nick has been created. I am going around. The third, and the capsulorhexis is over. So next part is hydrodissection. So for the hydrodissection, I just go in. I'm waiting for my friend. The way there it is, a slight dip, and that should be it. I would be showcasing stop and chop technique. ऐसा इस वजह करना कि जब ये प्रोटोटाइप को आप अपने हाथ से यूज कर रहे हो, सेटिंग कर रहे हो. Yeah, it's okay, it's okay. So I'll be using a balance tip. Now this balance tip gives me the advantage of better stroke length and lesser wound site injury. So here I go in. So I'm going in. The moment I go in, it is there. So I'll be doing stop and chop technique. Look at the chopper, it hardly goes in, but it is placed in such a way that there is a sculpt. I need sculpt. So I'm going in, trying to sculpt. So focusing all the way. I don't create a situation wherein I go all the way. The moment I find that it is adequately deep, that is the time I divide it. But here I find that even if I rotate it, then I can chop it. Quadrant removal, hold it, go full thickness deep, separate it fully. Could you see the chop?
Yeah, we can see it very clearly.
Yeah, go full thickness, foot position 3, 2, back to 2, go full thickness and chop it. So I'm again showing because I found that there are quite a few young people sitting there. See what I'm doing. Foot position 3, 2, embed it, separate it fully. Rotate it. Once I've been able to rotate it, again 2, 3, back to 2, full thickness, chop it. Now you can pull it out. I'm working at a deeper plane, but this, again rotate it. क्या कर रहे सर? Chop it. Bring it in the center, rotate it. I'm basically a traditionalist, I will not go searching for the nuclear fragment. I'm moving it to 6 o'clock. I'm not trying to pull it out from different angles. Totally separated. Keeping it right in the middle. I don't go searching. I let the fluidics work. Bring it to the center. You would have seen my phaco tip has not moved V-bit. The size of the pupil is the same. There was not undue efflux of fluid through the side port. No touching of the iris. No trauma to the iris. The pupil size remained the same at the start and at the end of the surgery. No, just visco. This is a slow motion phaco which I do. When you would have seen great, do very fast. But this is just to explain how things can be done. Can you focus on my hand? So I use a coaxial one. I use a by-hand coaxial curve tip. You will see how I use my both hands for that. My indications for using a bimanual are when it is a subluxated one, when it is open with a PCR in patients of intraoperative floppy iris syndrome. These are the patients where I use bimanual. You see how I'm using both my hands. I'm using my hand to rotate it, go to the subincisional cortex and pull it out. I'm using the vacuum diligently so that I don't catch the posterior capsule. I'm eating everything in the center, not doing the hurricane type technique as shown by Dr. Sri Ganesh and what people in our institute do. So it is done now totally, it has come out. Yeah, I need to, that niche looks down slightly. Hydro, yeah. So I do this hydro polishing, which there is some, you can see how it is going. Look down please. Niche dekhiye sir. Niche dekhiye sir. Light. Visco. So I'll be using Vivinex Impress here. I think it's one of the most, underscored. Why I would say underscored, underpriced and everything, because it gives such a big advantage. It is much better than, the competitive ones as far as the intermediate vision is concerned. It is based on Vivinex platform. This Vivinex platform, this Vivinex platform gives the advantage of least PCO, glistening free, and there are frosted edges of the haptic, which makes implantation, unfolding better, and it provides stable, rotational stability. So what I'm going to do now is I'm going to just push it around, and there it goes in. It has, it is an enhanced monofocal. It has structural changes, microscopic changes on the interior surface, which is a combination of an even order and standard is peri-surface. The surface combination provides better intermediate vision. The depth of focus is around 1.25 diopters. There is, decentration. It is friendly to decentration. The distance visual acuity is comparable to the monofocal intraocular lenses. So this is one of the best intraocular lens which I have used in this category, and the patients seem to be extremely happy with this intraocular lens. Thank you very much. I think it's practically done. Now I will do small bit of stromal hydration. Can you switch on the OCT? And can you focus on the incision? I would like you to see how, the incision gets sealed. So there are 3 different types of sealing. So it is centered. Stromal hydration.
So if you can see the OCT, it's wonderfully focused on the IOL and the bag. See?
I want you to focus it on the incision. Incision, can you focus? Yeah, there is no capsular bag extension. Here you can see. Now, where is it? Yeah, can you see? Yeah, can you see this incision? So when I loosen it, it will seal on its own. So it's almost sealed. Hydration, just pushing it here, and it is perfectly sealed. Thank you very much for your kind attention.
Sir.
Excellent surgery, Dr. Rohit, and the rhexis was perfect, like a femtorhexis. And you demonstrated the chop technique very well. So it's very important to, after impaling the nucleus, to hold it in with vacuum. So many of them, after they bury into the nucleus, they come out of phaco 2 to phaco 1, and that's when they lose the grip on the nucleus. So it's very important to have that fine foot pedal control so that you stay in phaco 2 when you're doing the chop.
Yeah, I think it's very important because you have to, the youngsters who are seeing it, they have to realize that foot pedal control solves practically everything. And the better foot control you have, the better you can control the machine. So you can play around in such a way that everything is under your control.
I think for this, the detents, setting the detents on the foot pedal also are very important. I like to have more play in phaco 2 so that I have, controlling it after impaling, and then you have a more leeway there in phaco 2. So that is something that you need to learn, and then set the detents properly on the foot pedal. If you have a very short detent on your phaco 2, that's when you keep losing grip. So the settings on the foot pedal also very important.
I think whenever I started with when I shifted from Infinity to Centurion, I could not get used to, because those people set in their foot pedal switches, foot pedal settings. So whatever foot pedal settings you are used to, you should try to incorporate into the new machine when you start using it. And that makes, suddenly when I changed it to my original setting, then there was no looking back. So foot pedal control, what you are used to, and using it meticulously is a very important factor in the whole scenario.
And also, sir, is beautifully shown, tapering your side port is a very, very important thing, because it creates much better fluidics. Sir, if you can elaborate a little bit on that and its benefit, that'll be good.
I call side port as stepson. Nobody bothers about it. And what happened is that in our center, we never have IFIS, because I personally believe that with side port calibration, wherein the side port instrument which I use is a 500 micron one, and the chopper which I use is 400 micron at the proximal end and 450 at the distal end. So what happens is that with this there is no undue efflux of fluid from the side port. So when there is no undue efflux from the side port, the chamber remains stable, there is no trauma to the iris, and when there is no trauma to the iris, you do not create a situation wherein the pupil suddenly constricts in those patients who are predisposed to pupil reconstruction. So this is something which has, with a small adjustment, and when you are using low fluidics, say 20 IOP and 23 this thing, if your side port calibration is there, it further adds to your efficiency as far as the dynamics of your phaco is concerned.
Thank you very much, Dr. Rohit. I think paucity of time, we'll move on to the next surgeon.
Yeah, the next surgery will be performed by Dr. Sonu Goel on a 61-year-old female patient with mature cataract, and the lens used will be Hoya Impress EDOF.
A very good afternoon. Am I audible? And is the
We're just showing your introduction, and then we'll switch the camera to you.
I'm good to go?
Yeah. Just a minute. Yeah. Yeah, good. Now we have the view, and you can start the surgery.
Okay. So I think this is a slight change in the patient. I think this is, we shifted to a new patient, 60-year-old female, and she's a homemaker, more interested in doing distance and intermediate activities, not much of near activity. So we chose to do an impress, and by default, most of my patients I've shifted from monofocal practice to this modified monofocal IO practice, because this gives an added advantage where people who drive can see the dashboards, intermediate activities, and for homemakers, I think this is a great boon in terms of, so I do 2 side ports, paracale. I would do, this looks slightly, viscoelastic, saline viscoelastic. So phenocaine by default gives me an added advantage to maintain that mydriasis and gives some amount of analgesia and anesthesia for patients under topical anesthesia. So viscoelastic. And yes, I'm saline, please, flush. 26. So I use the laser system routinely for most of our cataract. So, but for patients not affording, we would shift to manual or a phacoemulsification, then doing laser system. So I'm a great fan of stop and chop technique. So just demonstrating maybe a 5 or a 5.2 millimeter rexis here. Very carefully slide. I know there are clefts, so there would be a slight high intralenticular pressure, but I have been able to carve a rexis here. Flush, edge, 15. Saline, please, saline, please. Saline, no. We should not do it. Yes. So I do a 2-step main port incision. So I do an initial scratch, and then I do 2-step here, and then I enter. Hydro. So we've been doing Hoya lenses for quite a long time now, and I think with the advent of this impress and the geometry, most of the basket is complete and gives us a total refractive solution for most of our cataract patients. The stability of the toric lenses with the Hoya and their injector delivery system, I think these are the 2 major key factors which have really made us stick with these lenses. And the reproducibility with the delivery system is what I've been talking of. And the various other injector delivery system that we've been using have really not stood. And this is not the chopper, please. I want my chopper. I gave you my chopper, yeah. Yeah. Saline, please. Yeah. Can you give me some sharp chopper if you have? Flush please, flush, flush. So very lightly, so I'm using the Alcon Centurion. I use a vacuum. What is the vacuum reading? Can somebody tell me how much is the vacuum? 500, okay. You can enhance to maybe 600. So I use Signature Pro most of these times, but today I have an access to there are times you might be stuck when the lens doesn't rotate, so you have to keep your patience. Try, because I never dial because I don't want to stress the zonules before starting the phacoemulsification, because most of the fluid would then have passed, as you can see here. Slowly I'm trying, and then I just want to go 180 degree across, trying to separate the just the hold, which can actually do most of the job. Flush please. Vacuum 500, 600. So inner core looks a little soft relatively. So with the Hoya lenses, I think with the coming up of their geometry lenses, that paired approach has actually helped us out, to address patients who would crib for near and patients who would actually love to drive. So first is the first eye goes always by default a geometry. The second eye, depending upon the need of the patient, we can switch either to a geometry or a geometry plus. So at this point, I always make it a point not to withdraw the handpiece directly viscoelastic, visco, but then to keep the chamber deepened, never shallow, because this has 3 points. Whenever you are doing your posterior polar cataracts, it's a must. No folds on the cornea. It's not coming out. Visco is not coming out. Hold this. It's blocked, I think. No worries. Give me the irrigation aspiration. No worries. Saline, please. So, and it prevents at the same time chances of cystoid macular edema. So, I think the glow is there. Correct? So, I do as a routine bimanual because 3 advantages. It gives me a good control over the globe. I'm able to do the subincisional cortex very neatly, and at the same time I can polish the undersurface of the anterior capsule and the posterior capsule as well. So this is the subincisional part where you can actually exchange hands, a tip for the beginners. So this helps you to take away the subincisional cortex. Don't load that. I'll demonstrate the lens, right? So please don't load it, right? So this is how a little hydro polishing. Otherwise, I do as a routine polishing of the undersurface with a low vacuum. The undersurface on either sides, and a little. I just want to make it sure that the visual axis is absolutely clear. I use sandblasted polishing, polish it, polish it, polish it. make it sure that the visual axis has to be clear. I snugly sit on the posterior capsule. And visualize. Cannula block time, change the view. Okay. So it's not working. You can give me a bigger cannula. It's not working. Flush, please. Flush. Are you? So just quickly wanted to demonstrate the packing of the lens, viscoelastic, sorry. So this is, there are 3 steps where you load these Hoya lenses, and this is the XY1 impress. We're using a 20.5 diopter here, and so the step 1 is pushing viscoelastic. So you can see the viscoelastic moving out. The step 2 is you withdraw this. The step 3 is the advancement here. So this is, the optics are then advanced, and you can watch under the microscope, withdraw it, and then you have the advantage of both the swing and the push. So I use the push here, and when I advance, I gradually loop into the microscope. Then there are 2 advantages. You can either advance if you want in the bag, so I am looking for an in the bag implantation, or you can have a wound assisted, so you can just put it anteriorly. So here I am planning for a saline in the bag implantation. So as mentioned, the sandblasted appearance of the haptics of these lenses is actually what is the key to the stability of these Hoya lenses. So this is how you can have a direct in the bag implantation in most of the times. Flush, please. Flush. So I'd like to just demonstrate this, the beauty of the haptics here. So if you closely watch, the haptics are sandblasted, and I think this is that frosted appearance which gives these Hoya lenses that extra bit of stability when we are working on the toric platform. So it goes and snugly fits onto both the anterior and the posterior capsule once it's there, and the lens remains and sits where you have placed. So all in all, the reproducibility of the injector system, the great optics, their tolerance to decentration, and an excellent visual outcome with this impressed lenses has actually helped us to transform our practice from the routine monofocal to this advanced monofocal lenses. And the need for the addition has already been maybe a 1.5 to 1.75 diopters. And most of these patients with a bilateral implant fare very well, and surprisingly, with the backlit of the most of the mobiles and the iPads, they are still able to comprehend most of the near activities as well. So it's basically for the print that they require that near addition, and they are able to do most of their so I would, for the toric, always wash the undersurface and remove the viscoelastic from behind the lens. Hydro, please.
Excellent surgery, Dr. Sonu. You have
also it's not easy to operate on a machine which you don't regularly operate. So hats off to that too, because you have to really get used to the settings and many things actually before you
So
actually
I'm
start
thankful
operating.
to these iPhone guys which have given me the settings by them, their own experience, and I'm really grateful to them to help me out.
Wonderful, sir. Wonderful. It is very, very nicely done, sir.
We'll finish up the live surgery. Patients are doing that.
I think because of shortage of time, I think, sir.
We'll finish up the live surgery.
Yeah, you can proceed with the. Yeah.
So you can come to the OT.
So we'll be going ahead with the live surgeries first and then the talks.
All right, so there's a small change in the schedule. We'll be proceeding with session 3 of live surgery.
Now, the question basically boils down to what the personality and the need of the patient is. So between the EDOF and the trifocal, definitely the key factor here is the crisp near vision. So if the patient is not a very avid driver or is not a very type A personality and is looking at good near vision, definitely trifocal is the first choice here. But at the same time, if this patient is a young male who is a type A personality, very demanding and wants crisp distance and is very active driving, I would switch immediately to an EDOF, and that is where he would enjoy a good distance, good intermediate, and maybe a small add of near would make his life, very comfortable.
Another question was, we are getting a lot of post-refractive surgery patients today. Now, for example, you have a post-LASIK surgery patient. Would you choose a trifocal or would you choose an EDOF or would you not choose any of them?
So we had a long series of post-LASIK patients where we were taking these patients on Symphony lenses, which was an EDOF from one of the companies, and they were doing very well. So I think EDOF, yes, can be taken. And even for post-RK, maybe for 4 cuts where there is almost a symmetrical cornea, and yes, definitely after measurements of the aberrations, the angle alpha and kappa, and the symmetry of the cornea, which is very important, I think these patients do fairly well. But yes, in those extreme of patients where the cornea is too much flattened, where you believe that the contrast would be low, I think a good selection is which is very important. Trifocal, I would really discourage. If it's a very, a low diopter correction which has been done, yes, patients can be taken. But otherwise, EDOF still remains the first choice in my practice.
So in all these patients, we need to be very cautious regarding IOL formula because we need to hit emmetropia. If it's a virgin eye, we know that today's biometry, especially with optical biometry, it's fairly, we are confident about our biometry. But in post keratorefractive surgery eyes, whether it's RK or LASIK, you need to use the ASCRS online calculators, you need to use the Hay-Gizel or the Barrett True K. You do a topography and a tomography for all these patients. Look at the holiday pentacam EKR graph, look at the tall peak and see how much of keratometric variability is there, and only then go ahead and think whether a multifocal, whether it's a trifocal or EDOF, which actually suit the patient or not. And we need to counsel these patients very well because their expectations are sky high, and if you end up having a refractive surprise, because we know that mostly myopic ablations end up having a hyperopic refractive surprise and vice versa. So these patients need to be counseled very well regarding even night vision issues which can occur even if you have done a very good surgery and uneventful surgery.
And more important, these patients have undergone refractive surgery because they have always been vision demanding. So I think post cataract also, then they want that perfect emmetropia and perfect vision. So I think very rightly said that IL calculation has to be bang on target for these patients.
Right, absolutely. How much time do we have before we have the next surgery, or we can take a few questions?
So I think
We should start. Yes. Yes.
yeah,
Start
so
the talk.
Vector is being done, so we can have maybe one or two questions more.
So, whether it's the surgery or the talk.
It's Dr. Savios, sir.
Okay. Okay.
Talk.
Okay. Then start. Okay. One more question from.
So my question would be, sir, if you do have a post-operative refractive surprise in a trifocal IOL, what about corneal laser corrections? How often do you do it, or you would go ahead with the IOL exchange itself?
So if the question is to me, I would, a lot of times you face that there are refractive surprises, yes, but these patients can be addressed on the examiner platform. So we routinely do, maybe once we have seen that the refractive error has been stable, you have seen there is no dry eye, the ocular surface has completely recovered, and still the patient has issues with the refractive error. So I think good flap and examiner correction can be done, and patients behave amazingly very well, and their vision is almost like the perfect bang on target after that. So we have included this phenomena routinely in our practice because a lot of times you have minor cells remaining for which the patient still crypt, and once that is taken care, it's a very nice refractive correction can be achieved.
Yeah.
For
Thank you, Doctor.
IOL exchanges, if you have a very high amount of refractive error, which accidentally there has been a wrong lens implanted. So, IOL exchange holds true only in those circumstances where the refractive error is very, very high and you actually don't want to treat on the cornea platform.
Yeah. So, are we ready with the talk or this? Yeah.
So the femto is being performed, and Dr. Sheetal is here with me in the OR, and she's doing the lensa, and then the patient would quickly be rolled for the cataract surgery. So maybe
We have time for a.
two more minutes.
Okay.
Because I think with the talk, then the pupil might go down. So I think we need to.
So we won't have the talk right now.
Yeah, take the
Okay.
surgery
So
first.
yes.
We
Yes.
have
Discussion, yes.
Yeah.
So we were talking about the post-surgery refractive surprise. So what we do in our center is we do a refraction on the first day post-op. So for example, you have a patient having 6/6 N6 and you know that there is no refractive surprise, that's the best case scenario. The advantage of doing that is you have an idea about what is the induced cylinder or if there is a residual spherical error. Now if there is a residual spherical error say of -3 diopters. So it could be 2-3 options. One option is you may have put in the wrong lens. So you first go back to your biometry, go back to the lens sticker and see whether the right lens has been put or not. Secondly, it could be just you see the patient on slit lamp. If the chamber is shallow, if the lens has moved forward for whatever reason, maybe it's a wound which is leaking or maybe there is some fluid behind that, capsular distension syndrome, where there is fluid behind the lens and that is pushing the lens ahead. So you know what to do next. So if it's a leaking wound, yes, you need to address that. So either you patch the eye or if it's too weak, then maybe you go back and take a stitch and then you see the patient later on. If it's a capsular distension syndrome, then you need to address that fluid behind the lens. You either wait and see or you can just go back and tap the lens, get the fluid out, and that would be answered. If it's a wrong lens, then you know first day post-op if everything else is fine. Please let us know when the surgery is ready. Yeah? We are just discussing.
Yeah, Dr. Anuga, you're talking about capsular back distension.
Yes, yes.
Well, we have to realize whenever the patient...
Good morning, respected chairperson, dear friends.
Yeah, I think they're ready.
Is my voice audible?
Yes, yes, we can hear you.
Hi, Dr. Anuga.
Hi.
Hi, everyone. And at the outset, I am grateful to Netrathamani Hospital, Sri Ganesh sir, and Hoya Surgicals for inviting me to this wonderful CME. And I'm going to be showing the case of Hoya Impress enhanced monofocal lens implantation. My patient is a 68-year-old male patient and I'm operating on his left eye. The cataract is mature and intumescent cataract, and it also seems to be brown from inside. So the patient also has some amount of cylindrical power. Patient has a polygastric matrix of almost 1 diopter. So we have chosen to do femto laser cataract surgery for this patient because up to 1 diopter of cylinder can be easily tackled with the femto LRIs. And we also may have the advantage of a good well-centered capsulorhexis with the laser and also the nuclear fragmentation. But this case is like intumescent and brown cataract, so let's see how much the femto will help us. Is the screen visible? Microscope view is visible? Can you please switch the microscope view? Sir, light loading. So I'm going to implant the Hoya BVMX Impress enhanced monofocal lens in this patient. Patient already has a monofocal lens in the other eye, and he had a cataract surgery 1 year ago, and now the cataract has become like this, and we discussed with the patient the options. Patient wanted a lens that would provide him functional intermediate vision without any loss of quality of vision. So for this reason, this lens was perfect. So we'll be starting with the surgery now. So light loading. So case is being done in the topical anesthesia. सीधा note करें sir. Is it visible? Everything okay?
Yeah.
Okay, fine. So I'll start with making a side port and injection of intracameral xylocard. Light note करें sir. आराम So these femtorhexis, especially in these cases, mature and intumescent cases, sometimes can be quite tricky. We may not achieve a free-floating capsulotomy in these cases because of the fluid inside. Because of the fluid pockets, the level of the anterior capsule is not uniform all around, and thus the laser delivery also sometimes is not uniform, the laser energy, so that can lead to capsular tags. Single noding, sir, light noding. So I'll wait for a few seconds and allow the capsule to stain. Staining the capsule will help me to visualize better and also see if it is a free floating capsulotomy or not. So you can see most of it is free floating, right? But it looks attached little bit here. Look straight, sir. Sina Nodi. About 2 clock hours seems to be attached. So what I need to do here, straight node, light node. I will make my entry, side port, left side port. Can you know? How will? So it's never a good idea to pull the rhexis flat because it can lead to tear at the margin. So what I first like to do is I like to inject some visco under the rhexis and inspect if it is separating. Yes, you can see it is almost a free floating rhexis now. So I didn't have to use the rhexis forceps. Now, before going ahead with hydrodissection, I would just like to check if the nucleus is already mobile. Yes, you can see nucleus is already rotating easily. So I really don't have to do any hydrodissection in this case. This one? So I'm using the Centurion paper multiplication system here, and my setting at this time when I'm chopping is 50 flow rate and a vacuum of 700. So what I would like to do first is aspirate the superficial cortex. And I'm trying to see if I can visualize the pre-fragmentation chops, the grooves which were made by the laser. That's a limitation of femtotechnology. Sometimes the laser radiation does not pass through a dense cataract, so I will just do it my way. IUP कमी ಮಾಡಿ. Reduce the IUP please. You can see the chamber is quite deep. IUP bar is plus 20.5. So I will just reduce the chamber depth. The central core is quite dense. So I'll have to bury deeper. Okay. And I've got my first chop. I don't want to separate it too much. So I just want to separate it a bit superficially first. And then deepen my chops. Okay. So it's mostly a wide cataract, but little dense in the center. So I like to do multiple chops first and then emulsify all the fragments in one go. So I think I have made almost 5 to 6 fragments, quadrant. And now I shift to the quadrant setting. So at this time my vacuum is 700 and flow rate is 60. Quadrant 7 please. Visco. I generally like to inject OVD from the side port, so the chamber doesn't collapse suddenly. Especially we must be careful in these kind of cases, mature intumescent. Because the capsule and the zonular support system can be quite weak. Happy nucleus please. I would like to reduce my setting for the last piece since it's a mature cataract, just to be on the safer side. Visco please. And also before withdrawing the probe, I would like to form the chamber. bimanual. So here I have aimed at an axis of 5.5 with the control. And for this particular lens, which is the Impress, it is quite tolerant to decentration of up to 0.7 mm. So that's a good thing about the lens. So of course this is a femto case, but even if you are in manual surgery and sometimes the axis is not very perfect, so it can tolerate some amount of decentration very well without causing any visual disturbances to the patient. So there is some stringy cortex here in the periphery. Sir? You can also use saline to loosen this cortex, saline fluid, and then aspirate with irrigation aspiration. So the Hoya Impress lens, I'll just speak briefly about my personal experience with the lens, I will tell you please. So I have been using this lens now since about 6 months and have operated 25 patients or so, and I've seen very good patient satisfaction in terms of functional intermediate vision, and some of the patients have also got functional near vision also. Many patients are able to see N10, N8 easily, especially if their tree of pupil size is a bit small. And I've seen that the requirement of the near eye has come down to 1.5 to even up to 1.25 diopters. I think I'll go ahead with the implantation of the lens now. Okay. This goes. Sir, light. Patient is sleeping. Sir, aramagiri, सीधा लोड़ी. Light gonna start. Aramagiri, please. Lens आपके relax. So I'm sure the previous speakers, the surgeons have also shown this multi-surge injector. By far, this is the most convenient injector that I have used. You can see how easily it gets implanted. The lens gets implanted using this injector. Quite wound friendly when I'm on the scope. And if you can appreciate the unfolding was quite smooth. And you can also appreciate these texture haptics, okay, which help in the rotational stability in toric models. Gently I would implant the lens under the axis. So if you can see, the surface of this lens is quite smooth. The way this lens works and provides intermediate vision, reduce the IUP please. Chamber is very deep. Reduce. Yeah. So basically there is a optical element that has been provided in the center of the optic that has micro curvature changes. Now because of these micro curvature changes, it leads to variation in the power, and it has tiny peaks and valleys in the optical zone. So what happens is every pencil of light that strikes these peaks, it gets converged in front of the retina at different points. And because it gets converged at different points, it leads to an extension of depth of focus. And that is what results in functional intermediate vision. Just carefully aspirate these bubbles. You can see the lens is quite well centered. And you cannot really make out any impression on the lens. Obviously there are no rings, but even the topography of the surface of the lens looks exactly like a monofocal lens, IUPs. And this is the reason why patients are quite comfortable in the post-op period. They don't complain of any kind of dysphotopsia. Contrast sensitivity also is almost as good as a standard monofocal lens. Okay. So I'm just going to close the case. And if there are any questions, I'll be happy to answer.
Dr. Sheetal, can you hear?
Good morning.
Good morning. It's a good demonstration, very good, meaning you were very comfortable and calm while operating, and we are also impressed with the way you are speaking Kannada. My question to you is, I mean, for the beginners, what is the logical reason why you do not make your main opening and try to do most of your, including the staining, everything to the side port, and then finally you come to the main port? Any reason why?
Yeah, so because we want the chamber to be maintained at all the time.
But you
after
think,
surgery.
no, you think after making the main
Because
incision,
when you make the main port and then do all the manipulations to the main port, the chamber keeps shallowing.
okay. But it's very well done surgery, very well done surgery. Hey, what is that, arcade cut? If that's arcade.
Very loud round of applause for Dr. Sheetal. Congratulations. Excellent surgery, excellent demonstration.
Thank you, Dr. Anaga. I'll just form the chamber again. Hold my.
In the interest of saving time, we have yet to thank Dr. Anaga Madam. May I please invite her on stage? May I ask Dr. Savita Madam to please come on stage and thank Dr. Anaga Madam for her contribution today.
Fine. Thank you so much for your patience. So I think next would be Dr. Sri Ganesh, demonstrating the case of small pupil. Thank you, sir.
तुझा भाव कधी देना. He'll be very happy.
Good afternoon, and this is the 80-year-old male. Was also on tamsulosin, so you can see the pupil is very small. He just has a 1.52 millimeter pupil. I operated the other eye last week, and now we are going to do this case. So, light nodi, kanna last week. So you can see he's got a very prominent arcus, also very shallow chamber, and a small pupil. So the first thing is, after the incisions, I use xylocaine and adrenaline sometimes that you get a little bit of pupillary dilatation with that. The chamber is short. Then viscodilatation. When you put in the viscoelastic, you can see from a 2.5 millimeter, it has gone to a 4 millimeter just by putting adrenaline xylocaine and also viscometriasis. Now I'm going to so you go in and then you have to engage the pupillary margin in the nerves, the right side and then the left side. Okay. You can see that I have engaged the nerves. Okay. Then I have to finally put in I use this cholesterol dialer and then touch in the. So now you have a nice, good pupillary dilatation. Light and nodi. You can go ahead and do your capsular rhexis. I aim for a 5 to 5.5 millimeter rhexis. The cataract itself is not very dense, but he is an 80-year-old, so you expect some amount of nuclear sclerosis. So you're doing a hydrodissection, posterior fluid wave, nucleus rising, decompress, and rotate. When you do your hydro and rotation, you have an assessment of the nucleus. Put a little viscoat again. And the malignant ring is excellent in these patients on tamsulosin whose pupils don't dilate and who have IFIS. Without this, hello?
Yeah.
Without this, you can have a lot of issues. So this is a game changer, the malignant ring. So I am just doing a direct chop here. Rotate the nucleus. Again chop. So I like to make it into 4 quadrants. I change over to ozil and then I stay in the center and all the pieces come to the center, and you can see that
Sri, can I ask you a question?
Vacuum and 60 flow, so it's quite fast.
Can I ask you a question?
Yes.
Can you tell about your experience with BHEX?
Hello, volume.
Can you speak about your experience with BHEX in this case, in case you had to use?
Yeah, with the BX ring, it is actually has a smaller footprint, so it can go in through the side port also. And the only thing is it's a little more flexible than the Maligan ring, and so the kind of support for the iris is actually a little better with the Maligan, especially if you have a pupil which is a little rigid. If the pupil kind of expands, then you can also use the BX ring. And I use the BX ring and it is quite nice. In fact, the BX ring is excellent if you want to do a femto. You can just put the BX ring through the side port and then there's a hydro polish. So I remove the cortex. So the BX ring is good for femto. Whenever I want to expand the pupil and do femto, then I prefer the be extreme blind.
For the benefit of youngsters, in this case, could you have tried a stretch pupilloplasty?
If there is fibrosis, I mean if it's very rigid, then I do a little bit of stretch before putting the Maligan ring. But I try to avoid stretching because when you stretch, then you have sphincter tears and the pupil is not round. If you are able to get in the ring without stretching, then usually the post-op pupils are quite nice. And this is, I'm using a Hoya Impress, and with the multi-cert injector, you see I formed the AC with BSS. So I'll just show you. This is so I formed the AC with BSS, and then I am injecting under BSS. You can see the lens goes into the capsular bag, and you can also put in the trailing haptic. So you need to put in the viscoelastic to remove the ring, of course. So then I put in the viscoelastic. You can see that, of course, the textured haptic, and for torics the rotation stability is good. A lot has been spoken about the Impress already. It's got a central 2 mm zone, which is the modified reload it into the injector. So I just go in from the side port, detach the superior nerve, go in, engage it, and guide the middle nerves, and then it is easy. So that's the easy way of removing the Maligan ring, and you can see that the pupil, there is no sphincter tears as such, and there is no visco underneath the lens, because I put the visco after injecting the lens with BSS. So routinely I inject all my lenses under BSS, and for torics I find that the rotation is less. And actually I don't need irrigation in the side port also, because the chamber kind of forms well with just BSS. And it obviously 2 steps you are going to say, putting in and removing the viscoelastic. So you can see there was no viscoelastic behind. I'll show you the OCT. Just hydrate the lens very gently. You can see there's a little bit of a dismiss detachment which you don't have to do. In older patients, you can have that at the incision site. But you can see the chamber is very well formed, and this is the Hoya Impress. I'll just show you the OCT basically. You can see the OCT image there, and as I go posteriorly you can see the lens there. And the PC is there. Of course, this is a large bag because he's an older patient. Once you depress again, you can see the folds in the back. That shows that there is no viscoelastic in the bag. You see those folds there. So and you can see the PC just under the lens. So there is no viscoelastic because I injected with BSS. And the eye is formed. If you look at the wound, you can see that the wound is hydrated. Of course, there's a very small DM detachment, so you don't need to put in air there because that will attach. So it's bigger than you need to put in air. So that's the end of the surgery. Small pupil, it's quite easy to manage if you have a pupil expander. I'll show you the other eye which I operated. I'll show you the other eye which I operated last week. So this is the other eye. You can see the pupil size is very small, and you can see that if I done a stretch pupilloplasty, you won't have this kind of a nice, round, regular reacting. You can't even make out that anything has been done to the pupil. So that's the beauty of the mannequin ring. Small pupils, you get an excellent result.
Beautiful, beautiful. Congratulations.
Thank you. So our next surgeon will be Dr. Naren Shetty.
Right here, ma'am.
That's it. Can you Good afternoon, everyone.
Yeah, good afternoon, good afternoon. We are looking for, yeah.
Okay, fantastic. As a concept, I'd like to thank Dr. Sri Ganesh for giving me this opportunity, and also Hoya and also Dr. Supriya. So today we have, just come to Kanya, please. Visco, Kanya. Yeah, Visco. Alright. So if you see usually I create a very extremely short label main post, and it's ideally, I think efficacy. If you have a little bit of folds like this, intercameral adrenaline is good to use. No, intercameral adrenaline. You have? Oh. So always remember, if you see a little bit like this, it looks harmless, but it's always good to use a little bit of adrenaline. Automatically it will make it a little more stiffer. So what you can do is just leave it for a few seconds, fill the chamber, and then you can begin our exit. Sir, light A ನೋಡಬೇಕು, ಅದು ಮೂರು ಬಲ್ಬ್ ಇದೆಯಲ್ಲ ಸರ್, ಅಲ್ಲೇ ನೋಡಬೇಕು. So once we have done that, we can start our exit. So try to the thing is about rectus test, try to make a large flap in the beginning. Once you have done that, you can try to, fold it and then keep pushing it. Do it in small strokes so that it's much more controlled and centered. So whenever you do your hydrodissection, one thing is, a small tip is, the cannula should be parallel to the rectus, or parallel to the capsule. Once you're just under, then now you can see your first wave, and then you have your second wave, and you're good to go. Okay? Saline wash without cannula, please. Saline wash without cannula. Right. So once you've done that, always fill the chamber completely with viscoelastic before you start your takeout. This is a small tip because sometimes, can we reduce the speed, please? The tip exposes too much. So it's important to fill the chamber with viscoelastic and then begin. This will further protect it because sometimes when you're doing the tip exposure is small. Yes. Smaller. So one of the small things, actually it's not good to keep this less tip exposure, but I normally do it. One of the reasons why, light noise there? So why I normally do that is, it keeps the irrigation ports little away. So now if you observe, when the irrigation port is half and half out, I press 1 and then only enter. Okay?
So once that is done, you can see it's not a too hard cataract, it's still okay. So once you remove your superficial cortex, what is important is your angulation. And once you've got a good angulation, go a little deep if it is softer cataract and you chop. You don't need to go to periphery, take your dialer to the periphery to do your chop. Again, good hold, a little deep chop, separate. Again, good hold, deep chop, separate, and then we just have to repeat the same. So
Dr. Naren, what are your settings right now?
So if you look at my settings, it's 22 IOP. I hope you can focus, before I start, yeah. Can we focus on the screen, please? Is it visible now? If you look at my settings, it's 22 IOP, and it's a fixed vacuum of 700, fixed vacuum of 60. So directly jumps up to the flow and vacuum. And also the torsional phaco starts from 40 and goes to 100. Why 100? 100 is not necessary for everything. It's just that I just keep one setting for all my phaco so that no matter what I operate, I can just use my foot control to choose the delivery. So now let's begin. So usually I remove my second hand piece. So now you see there's no leak from the side port. So once that is done, what is very crucial is a wonderful thing that see you have to keep the phaco tip in the center. Okay? And let the piece come to you and look at the speed at which it comes. And I'm not moving my, I only press 3 when I am in the center and in a very deep plane. If you look at my plane of phacoing, it's almost just at the level of the capsule itself. And it's super, super fast. So once that is done, I saline please. So what I do is, because I have time now, while they are exchanging, what I take the saline, I wash off my visco from the angles. Can you see a little bit of visco being washed from the angles? Again, from this angle, I wash it off. Okay, visco on the cornea, and then I take my IV. Okay, so normally I just fill the chamber from the main port a little bit, position it into that, and then take it in. So once this is done, I think I is pretty standard. It's not a big deal. I think, like everyone was mentioning, always remember to change your hand once you finish one side. And what I normally do is I always take my always take my irrigation on my right hand first and then shift over so that I can continue with, you rotate it. Okay, so just one sec, hold on. So if it's collapsing like that, what you have to do is switch off your irrigation, then switch on. So this is under irrigation itself. So what is very key is the slit which is below, you should be inside the chamber itself, and then you can use your irrigation to guide it. So it's under irrigation itself. Now what is very important is, now if you feel a little bit of the iris is prolapsing, just position like this, and then hold the edge of the IOL, lift it up, and then put it inside. Don't ever try to push the IOL directly down. If you push it, it damages the iris a little bit. So I hold the edge, push it to the center, then go down. So that will, it really helps with the, that you don't damage the iris, and then it doesn't release further prostaglandins and so on and so forth. Now, if you observe what I do now, visco on please, no saline, just visco. Okay, now I just want to show you something. Now, whenever I do wash now, see, I have not put visco after and for my delivery of the lens. That means whatever visco is there in the chamber, it was there even after I finished my phaco. Now, if you observe, I don't know if you can observe the cornea, from the endothelium still there is visco. So that means I don't need to see my post-ops tomorrow, 100%. The cornea is really, really good. So then what I do is, okay, once you remove from the cornea, I always take my irrigation below, remove the rest of the leftover viscoelastic. Can I have the overlay please of the alignment? Oh, okay. Okay, can I have my 3 glasses? Yeah. So don't worry. worry that, okay, oh, I can't rotate it anti-clockwise. No, you can rotate it anti-clockwise also. What you have to do is you have to push down and then rotate like this. So push down, rotate. Push down, rotate. So this way you can actually even rotate it anti-clockwise. Can I have the 3D glasses, please? Yeah. So once that is done, you can orient your the toric lens. Does it look centered? Maybe a little bit. I think this should be good. You can always put it better. Okay, good.
It looks
So
perfectly aligned.
Excellent, thank you. So you have a good overlap. Can you remove the glasses, please? Yeah. So you have a good overlap of the rexis also. So what you have to do is whenever you finish your case, see the irradiation on, you have to take the saline, hydrate one of the side ports so that the chamber doesn't collapse, and then you can continue with the hydration of the rest of it. So if you observe, so it's a little on the floppier side. I mentioned, no, that whenever you see that kind of a case, and then after you put intracameral adenine and it still doesn't dilate, usually it has a tendency to collapse, prolapse a little bit. So you should be a little more aware of those cases. So after this, I think once we have a good alignment, I think we are good to go.
Excellent surgery, Dr. Naren. Congratulations.
Naren, congratulations. A very clean surgery. And your single-handed phaco was also a nice way to do it. Beautifully demonstrated. Congratulations.
Thank you, sir. Thank you, sir. So basically, I mean, if you look at the settings, so one of the important things what we have to do is, see what I normally use is just a pinch of longitudinal power. That's the beauty about the Centurion system. We have both torsional and longitudinal if you want to use it. So just a pinch so that there's a little jackhammer effect of the lens so that it heats very quickly. The same speed you can operate even in a black cataract. There is no difference at all. That is the beauty of the machine. And the lens which I use is basically the enhanced monofocal of the Hoya. It's a fantastic lens. One of the things I think it's been wonderfully covered already, all the information about the lens. But one key feature which I find is very unique is it maintains the quality of the optic. That's the only lens which has the least amount of glistening and hairs over time when you compare to the rest of the competition. And obviously the enhanced monofocal gives a little better, at least a one-line improvement in terms of the intermediate, because nowadays intermediate vision has become very important, not just for looking at computers, even for cooking and so on and so forth is extremely useful. And it really doesn't, it behaves more like a monofocal lens in terms of glare and halos. So it's a fantastic lens. Thank you so much, everyone. Thank you.
Thank you, Naren. Thank you.
So we have about a minute's delay. Dr. Rohit sir will be joining us shortly and he'll be delivering the next talk. We are done with all the live surgeries for the day. So what's left is all the didactic lectures. Dr. Rohit sir is here. So things rarely go as per plan, just like the schedule of today's CME. And that is exactly what Rohit sir is going to be talking about. His topic is unhappy patients after a multifocal IOL. So your laptop is right here on stage. So the stage is also yours, sir.
Jan
I would like to congratulate Dr. Sri for coming out with an excellent day wherein each one of us has gained from surgical sessions and from the talks by all the faculty members. So I was asked by Dr. Supriya to talk on unhappy patients after multifocal IOL. Well, we have to realize that the number of unhappy patients have decreased over the years because of advanced technology with biometry and better intraocular lenses which are coming up. But still, there are quite a few unhappy patients. So one of the first and foremost thing which happens is that there's an undiagnosed or unmanaged residual refractive power. It could be spherical or the cylindrical. An ocular surface issue can be there. There can be higher order aberrations. PCO, though minimal, may be the cause. And if the patient is paying so much, and if a retinal pathology is missed or has come up, is also one of the cause for an unhappy patient. Dysphotopsias, negative, positive, they are also there. Very rarely decentration and poor neuroadaptation. Well, it can be because of surgery, or it could be because of the patient, or it could be because of both the reasons. Well, if there is some residual refractive error, even though it may be minimal, but it may be causing blurry distance vision and bothersome night vision symptoms. So this could be at times because of residual refractive error, and there might be small amount of residual astigmatism which could be there, which would have not been taken care of, which would have caused an unhappy patient. So by all means, wherever you can, you should, as Dr. Naga Harur said, that you should add toric intraocular lens rather than a simple multifocal or a trifocal intraocular lens. And you just punch in, and if it comes, you do add a toric element to your trifocal also. So if the error is a spherical refractive error, and if the patient is happy with glasses, well, mark my words, if you have told the patient that you will have fairly good vision and you may need some amount of glasses, then he may buy the idea of using glasses. But if you have overplayed and you have not been able to deliver, and the patient is not happy with the concept of using glasses, then LASIK or PRK may be planned. And if by any means there's an astigmatic refractive error, a toric intraocular lens, if it has been implanted, then you can fix it by using astigmatismfix.com, going in there and doing IOL repositioning. And if the patient, and if you by any means you have not put in a toric intraocular lens, and if the patient is not happy with glasses, a LASIK or PRK may be added. So optical biometry should be used, newer formulas, multiple formulas, as we have the ESCRS, on the ESCRS website, you have multiple formulas where you can come out and decide which formula has to be used. And if you by any means, toric intraocular lens implantation, if you have to do the biometry, it should be done before any manipulation of the eye. And if there is any variation, it should be repeated, and ocular surface should be clearly dealt with, and if possible, managed before really coming out with the final biometry. Well, we have to tell the patients that multifocals won't eliminate the need for glasses, but they can reduce dependence on glasses. So mesopic and scotopic pupil size has already been dealt with, because at times surgeons around, they really do not go into the detailing of the mesopic pupil size and scotopic pupil size, which adds to visual quality disturbances. So at times pupillary modulating drops may have to be used. Ocular surface has already been dealt today, but that has made my talk a little simpler. It may be associated with ocular irritation, stinging, but there may be some amount of blurred vision or fluctuating vision. So ocular surface needs to be taken into consideration before we really, I'll just show a case study. So it can be, this ocular surface precipitation can be because of corneal nerve disruption, or it can be a post-operative inflammation, or it can be subsequent to prolonged use of preservatives containing topical medication. So here you would find that there is irregular astigmatism, steepening, and everything is there. So the patient was, and you can see how below it is there showing that the quality is not good. So the patient was put on lubricating topical drops, and you will find that after 1 month, what we have been able to achieve, a satisfied patient in this condition. So if there is fluctuation in vision, it could be because of ocular surface. So in that condition, neuroadaptation, you have to let the patient, you have to talk to the patient, you have to let him know, you have to buy time, because in the majority of the patients, you create a situation where there is neuroadaptation and the patient becomes from an unhappy patient to a happy patient. You have to realize that you have to tell to the patient that because you have to realize that the patient was 100% trusting you. So he will trust you also. All that you need to do is you need to counsel him, you need to talk to him. And in the worst case scenarios, IOL exchange at times is the answer. There are times when the best corrected visual acuity is less than 6/6. This has already been talked about, refract, ocular surface. PCO is one thing which does come up in mind. So a very careful examination of posterior capsule needs to be looked into. Macular pathology, if it was pre-existing, is not, you should not be excused for that. Because if the patient is paying such a lot amount of money with such a lot of expectations, macular OCT is obligatory and mandatory in these patients. And if by any means it has come up, then it should be adequately dealt with. Now, talking about posterior capsular opacification, it can be that the visual acuity might have decreased, or the adequate visual acuity has not been there right from day one. So now the question is, what should we do for PCO? Well, we have to wait for YAG laser capsulotomy, because if by any means there's a need for IOL exchange, and if you have done YAG laser capsulotomy, then it becomes really difficult for you to do an IOL exchange. Because at times, because of dysphotopsias, glare, halo, which is disturbing to the patients, at times, IOL exchange becomes obligatory and mandatory. So PCO, if it is there in the form of wrinkling of anything, you have to be very careful in deciding whether you have to, whether you should do YAG laser capsulotomy or not. Decentering and tilting is a rare phenomenon, and this has already been shown by Dr. Sonu Goyal in his previous talk. Higher order nowadays, what we are doing is we are using the eye trace for eye trace, no financial interest whatsoever. This helps us dissociate whether the aberrations are on the corneal plane or the lens plane. And if by any means you have missed it, then it really becomes something which creates a situation the patient becomes unhappy once for all. So this is another situation where you will find that the DLI score is more than 7, but the corneal aberrations, corneal problem is more. So here in this situation, a trifocal or a premium intraocular lens should not have been used whatsoever. So fluctuations, photopsias, and the quality of vision, if by any means they are not being managed and neuroadaptation is not getting you through, then IOL exchange becomes obligatory and mandatory. So preoperative evaluation is mandatory. Discussion of patient's needs and expectations. Corneal topography, higher order aberrations are obligatory and mandatory. You should know you should discuss with the patient his needs and expectations, occupation, hobbies, quality of vision, and near vision distance before really deciding which intraocular lens we should go in for. Concluding appropriate patient selection and evaluation and expectations, you have to create a situation where the expectations meet with what you are able to deliver to the patient. Thank you very much for your kind attention. Dr. Sri, you are very much into these premium intraocular lenses. So if by any chance the patient has been missed out on, these higher order aberrations, and if he comes to you, so what is your game plan? You wait, you make the patient understand, or you?
do a complete assessment, many times the aberrations can also be because of dry eye. So you always have to do a dry eye assessment and then check.
Yeah.
You also have to check if there is, something like abortive keratoconus, irregular astigmatism. Many cases, some cases I've seen of, toric premium IOLs, multifocals, trifocals put in, and patient is unhappy, and when you do a topography, there is a, early abortive keratoconus with a little bit of
Yeah.
skew and, inferior steepening, and these patients have a lot of coma, so they are unhappy and loss of contrast also.
Yeah.
Counseling, yes, will help over a period of time. They kind of adapt because the brain adjusts.
Yeah, absolutely.
So I think you need to give at least 3 to 4 months for neuroadaptation. If they're not adapting, then probably by 3 or 4 months do a IUL exchange. If you think that it's going to improve.
I was talking with Matteo Paovella. So he puts, as you're aware, in practically all the patients. And what he tells the patient is that I'm giving you something new and your body needs to adjust with it. So he makes the patient psychologically ready that it will take around 6 months for him to get used to.
The same thing, I tell them that it's going to take time,
Yeah.
and your night vision is going to get better over time, and it will take almost a year for it to, completely,
Yeah.
for you to be comfortable. The halo will never go away. That shows that the lens is working.
Mm-hmm.
If you see a halo,
Mm-hmm.
that means the lens is working. It's focusing both for distance and near.
Yeah.
If you don't see the halo, that means you're not focusing properly. So when I tell them, then see, you need to explain the phenomenon and just reassure them that it is okay.
Yeah.
So with that, I think most patients are okay. So you need to tell them that this is
Yeah.
expected, it is normal to have this.
Yeah. I
With
think that's
time
the
it will
most important clip. You have to talk and you have to continue talking and call them after longer periods of time rather than, calling them back again and again so that, mentally also and, they get.
No, but there are basically two kinds of patients. Patients who are comfortable with multifocality and who will not have contrast issues. There are two aspects. One is the night vision and the dysphotopsia. The second is a contrast issue. So some of them, from day one, they say that the vision is very waxy, it's kind of oily, I don't see sharp.
That's a dangerous issue.
But there are other patients who don't actually complain. So there are two sets of patients. Some patients cannot kind of put up with this kind of a contrast. And they are the most difficult patient and they take a long time.
Yeah.
See, dysphotopsia, night vision, that is explained. But this is something that, so there are some patients, but these patients actually do well for micromonovision.
Yeah.
I tried multifocal contact lenses.
Okay.
And I was miserable with multifocal contact lenses for presbyopia. Night vision was terrible. But then I tolerate the micromonovision very well, and with presbyon I'm very happy.
Oh, great.
So again, it's like, but it's very difficult to find out which patient will tolerate multifocality or not until you put the lens.
Yeah. Thank you very much.
So we know you're in a hurry, but can we take half a minute of your time to thank you, sir?
Good afternoon, everybody. I think everybody is hungry. We are running a little late or a lot as far as the program is concerned. So my talk is on new generation trifocals and explaining the technology behind the geometric, but Dr. Anaga has already covered this in detail. So this will be a repetition. So I'm just going to cut to the chase and then give our experience and my experience of using these lenses. Of course, this is, she has already covered this, that it is a differential light distribution and they complement each other to get good distance, intermediate and near vision. Those are the specs, and I think all this has been covered. So let's go directly to the clinical study. This is a prospective single center study. 52 eyes of 26 patients so far. Mean age 64 years, cataract in all patients, no clear lens extractions or refractive lens exchange. And we did the second eye within a week, and all of them had flax surgery. There were no complications reported, and we have a 2-week follow-up. We found that binocular distance visual acuity at 2 weeks, 98% of eyes had, of patients, this is binocular vision, 98% of patients had 6/6 or better, and all eyes had 6/9 or better. So excellent binocular vision for distance. If you look at the near visual acuity at 2 weeks, all of them, 100% of them had N6 or better, and 39% of eyes had N5. So this is again excellent results for near. Post-op residual refractive error at 2 weeks, when we did the refraction, 94.23% had spherical equivalent within half a diopter. That is spherical equivalent, which is within half a diopter, which is excellent because here we are using the IOL Master 700, newer biometric formulas, optimizing the ocular surface before biometry, and also using flax and torics whenever required, or if the astigmatism is less than 1 diopter, corrected with relaxing incisions. So 94% of eye spherical equivalent within half diopter is excellent as far as results go. And we also did we used the Salzburg reading desk for evaluating the reading speeds, because the reading speeds, the reading ability gives a simulation of the functional vision, and this is important rather than just asking them to read words. And this is how we perform the SRD. This is the instrument SRD. So the distance between the eye and the reading material is monitored by putting a infrared dot on the forehead, which is monitored by infrared cameras. The patient keeps reading out the lines, and then through a microphone the reading speeds are recorded, number of words per minute. So we check the reading acuity at 40, 66 and 80 centimeters at 2 weeks, and you can see that's the reading acuity, and you can see it is good at all distances, 40 centimeters, 66 and 80 centimeters. This is because we implanted geometric in one eye and geometric plus in the other eye. These are the reading speeds. Reading speeds over 100 words is excellent. So again, we checked at 40, 66 and 80 centimeters, and you can see that the reading speeds at all distances are above 100. In fact, more than 150, and at 66 centimeters, which is the intermediate vision, it is excellent because there's a very nice summation. This is the binocular defocus curves at 2 weeks post-op, and you can see that they get almost about, if you look at the visual acuity in logmar at 0.2, they get almost 3.5 diopters of pseudo accommodation or range of vision. This is the contrast sensitivity at 2 weeks. You can see that the contrast for the higher spatial frequencies are almost within the normal zone, but as the spatial frequency increases, it kind of drops, but it's in the lower range of normal. So the contrast, binocular contrast is fairly good even at 2 weeks, and we expect the contrast sensitivity to improve by about 3 months to 6 months. And this is the patient satisfaction score with binocularly for distance, intermediate and near. The score was based on a questionnaire, and the satisfaction score was 9.54 out of 10, which is excellent. And as far as spectacle independence is concerned, 100% of them had spectacle independence for distance, intermediate and near vision. So to conclude, trifocals improve near, intermediate and distance vision in patients with cataract surgery who want to be rid of glasses. Use of 3 foci provides significant intermediate visual acuity results without sacrificing near and distance vision, leading to spectacle freedom. And pairing the Vivinex geometric and geometric plus delivers a continuous range of high quality vision for spectacle independence. from distance, intermediate and near. And as of now, pairing is the most balanced approach to achieve the highest spectacle independence and also the least number of side effects and dysphotopsia. Thank you very much for your attention.
So the only person in this auditorium who can thank Dr. H.G. sir for his contributions is Dr. Suhas sir. Can I please ask Dr. H.G. sir and Suhas sir on stage, please? Just as a felicitation. Yeah. Next we have Dr. Sheetal Brar ma'am, who will be talking about her practical experiences with the Hoya Vivinex toric IOL.
One ನಿಮಿಷ. ಐವತ್ತೆಂಟು ತೊಂಬತ್ತ್ಮೂರು ಆಡಿಯೋ ಇಲ್ಲಂತೆ.
Full screen. ऐसे ही आएगा क्या? Full screen नहीं आ रहा है? So good afternoon everyone. I'll not take much of your time. I'll just be discussing the results of a clinical study that we recently conducted in Netradhamma. And this study was about evaluating and comparing the clinical outcomes and rotational stability of the Hoya Vivinex toric IOL in normal versus large axial lens. Yeah. Let it be, it's okay. I can see. So I'll skip the technical part of it. कैसे जाएगा next? Okay. So we, huh? ठीक है ना? मेरे को नेक्स्ट करना है कैसे? तो हो ही नहीं रहा है. Dr. Savi, your presentation is ready? They are having some issue connecting it.
Yes, done.
करो ना. हाँ हो गया ना अभी. ठीक है ठीक है. So apologies for the technical glitch. So the study was about evaluating and comparing the rotational stability and clinical outcomes between eyes with normal axial length and large axial length. So as cataract surgeons we know, and as premium cataract surgeons we are aware that the rotational stability of toric IOLs is a little bit of question in eyes with high myopia. So many times I've seen a lot of surgeons, they do not like to advise toric lens to a patient who has high myopia, because the chances of post-op rotation are thought to be higher in these eyes, because they have large and loose capsular bags. The weak and relaxed zonules also kind of can play a role in the post-op rotation. And this is why it is sometimes not preferred by some surgeons to use toric lenses in high axial lengths. So in this study, we used the Vivinex toric intraocular lens with the multi-cert injector. I'm not going into the details of the technical specifications. The lens can correct a corneal astigmatism from 0.69 diopters to up to 4.19 diopters. And it is manufactured on the proven platform of the Vivinex with the glistening free material. Now, what is more important for you to understand and what we wanted to evaluate exactly was the feature of the textured rough haptic surface which the Hoya company has provided on this lens. So basically you have to understand that this whole haptic, okay, you can see this whole haptic is textured. When we say textured, it means it is frosted and slightly roughened, okay. On both the anterior and posterior surface, both the haptics are textured, and also the edge of the haptic is textured and the edge of the optic is textured. Now, why this has been done is basically to improve the contact and grip of the lens with the capsular bag to prevent post-op rotations. Now, coming to our study, basically the purpose was to compare clinical outcomes and rotational stability following implantation of Vivinex toric in eyes with normal versus high axial length. It was a two-arm retrospective comparison study. We had 114 eyes from 114 eligible patients, and all patients underwent flax with Hoya Vivinex toric IOL. So the procedure was standard, and it was a single surgeon series. So Dr. Ganesh performed all the surgeries using the flax technology. So in the normal axial length group, we had 62 eyes, and in the high axial length group, we had 52 eyes. And this was demarcated based on the axial length. So any axial length which was less than or equal to 23.9 millimeters was categorized as normal, and anything which was equal to more than 24 was high axial length. Evaluation was done at 1 week and 3 months post-op. Now, when we look at the preoperative data, you can see that the age and keratometry and corneal astigmatism was perfectly matched between both the groups. However, the axial length, anterior chamber depth, and white to white was significantly larger in the high axial length group, and this is obviously expected because these are high myopic eyes. So definitely you will have a significant difference in terms of the axial length, and ACD will be deep, and the white to white also will be large. Now, this was just a short video to show how the implantation was done. So all implantations were done under DSS. And you can see that the lens was positioned on the toric marks, the IntelliAxis toric marks, which the LENSAR laser provides on the capsulotomy. Okay, so this is quite simple. Even Dr. Ganesh has today shown his technique in the live surgery as well. Okay, you can see the excellent stability of the lens. Once the IA probe is withdrawn, the lens doesn't move at all. Okay. So coming to our results at 3 months, the number of eyes achieving 20/20 uncorrected vision was 74% in the normal axial length group and 73% in the large axial length. So this was quite comparable. And with regard to the spherical equivalent accuracy, 97% eyes in the normal group were within plus minus 0.5, and 100% of eyes in the high axial group were within plus minus 0.5. With regard to the refractive cylinder accuracy, all eyes in the normal axial length group had a post-op refractive cylinder within plus minus 0.5 versus 94% in the high axial length groups. And how did we measure the post-op rotation? So for that, we had the value of the intended axis, which was our target axis, right? And what we evaluated in the post-op period was the achieved axis, basically where our lens is now sitting in the post-op period at 1 week and at 3 months. Now, as a routine, we dilate the patient's pupil and we measure the post-op rotation. Now, when you do that on slit lamp, right, you cannot measure it to the accuracy of 1 degree, right? Because on slit lamp, you have 5 degrees or 10 degrees, the gradation. So you're not able to basically measure it to the accuracy of 1 degree. But what I used was in this study an online protractor tool. Okay, so this is a tool, and you can see that it has all the degrees from 0 to 180, and you can see that where the toric marks are, right? You can basically draw a line passing through the center of the toric marks, okay, and that was taken as the achieved axis. So the rotation would be calculated as intended axis minus the achieved axis. In this way, we evaluated the rotation. Now, these are the results. At 1 week in the normal axial length group, the mean rotation was only 1.2 degrees versus high axial length group where it was 1.4 degrees. So you can see it's less than 2 degrees, hardly anything, even in the high axial length group. At 3 months, it was 1.48 in the normal axial length group and 1.67 in the high axial length group. Again, in both the groups, the post-op rotation final, because usually after 3 months, it does not really rotate. So finally, the rotation was within 2 degrees in both the groups, which is excellent. And there was no statistically significant difference between the 2 groups. And if you look at this chart of the post-op rotation, at 3 months in the normal axial length group, all 62 eyes were within 0 to 5 degrees. And in the high axial length group, 50 eyes, so we had total of 52, 50 eyes were within 0 to 5, and 2 eyes were within 5 to 10. And precisely it was just 6 degrees. Okay. So we also did vector analysis. Basically, it is a way to see whether your IOL, toric IOL is overcorrecting or undercorrecting. So we see a parameter which is called correction index. So the ideal value of CI is 1. If it's anything more than 1, it shows overcorrection. Anything less than 1 is undercorrection. And you can see here in both the groups, it is close to 1. 1.02 and 0.99 is almost 1. So pretty much, perfect correction was achieved. Now, we wanted to see the effect of axial length and preoperative parameters on the post-op rotation. And we found the Pearson's correlations, and we saw that the axial length and the white to white and ACD did not correlate with the post-op rotation, which means that when you use this particular lens, it really does not matter what is patient's axial length, ACD, or white to white, because all these factors were independent and did not play a role in the post-op rotation. So how you know that, basically? This is just a little bit of stats. So this is the R value, right? The more positive it is, it shows positive correlation. Negative it is, then negative. But only if the p-value is positive. So we did not have any p-values which were significant, and thus there was no correlation found with these pre-op parameters. So this was another study by authors, and this is a German name. It's difficult to pronounce, but this is a landmark study where they found that the mean rotation, this was the true rotation of the toric Vivinex, the monofocal Vivinex lens, where they found that the mean rotation was 1.1 degrees only at 6 months post-op. And this was a study which was exactly similar like ours, where they compared the results between normal axial length and large axial length, but the IOL was Acris of IQ toric. And look at the results, okay? So with the Acris at 3 months, the average rotation in the normal axial length group was 4.16, but in our series with the Vivinex, it was 1.48. And in the large axial length group, Acris had 4.27 degrees, and in our study, it was 1.67. So basically, less than half amount of rotation was seen with the Vivinex compared to the Acris. So to conclude, in our study, the axial length and white to white did not significantly correlate with the post-op rotation, and what we can attribute these excellent results to is the haptic modification, which essentially is the textured surface and the edges of the Vivinex toric, and thus they enhance the contact with the capsular bag and result into excellent rotational stability in all eyes. So when I say all eyes, it means irrespective of their preoperative axial lengths and white to white and the capsular sizes. So thank you so much. So essentially what it means is that you can advise toric IOL, Vivinex toric IOL, even in eyes with large axial lens or high myopia, because there is no difference between the post-op rotation compared to normal axial lens in our study. Thank you so much.
I'm going to stay on stage. To stay on stage for the felicitation. May I ask Dr. Savita ma'am to please come? All right, our final talk is by somebody whom you have barely seen today, because he has not been in the auditorium at all. Not just for today, but for the past several days, he has been running around to make sure that the operating room performs smoothly. So the live surgeries that you saw today, if you want to thank one person, that's the next speaker that's coming up, and that's Dr. Savio Silvan Pereira. May I invite you for your talk, sir?
A very good afternoon, everyone. And I know you are all hungry, and thank you for the very, very warm welcome. So I will just give you all a gist. So yes, you have enhanced vision. Now, some people ask me, what is an enhanced monofocal and what is exactly an EDOF? It's very simple. True EDOF lenses should have a ring on them, and that step itself can induce some amount of glare and halos. While enhanced monofocals, they don't have a true ring. What they have is an optical element which is a smooth bump which just gives some amount of a spherical aberrations which help the patient to see better. Now, today's world, everybody wants to see intermediate. Our computers, our mobile phones, you're driving, you don't want the glare and halos, but you want good intermediate vision. So that is where enhanced monofocals come in. And what you understand is that the beauty about this lens is the dioptric power that you get. You get from +6 to +30. This is something which you don't get with all types of trifocals. And also a 2.2 incision. This has already been discussed in details, and as you can see, there's no ring on the lens, and what you see, this light shadow is just to highlight where the 2 mm zone is actually inducing the optical changes. It's based on the Vivinex platform. Enough has been discussed about this and even about the multi-cert. But what are our results about this? So we have operated about 44 eyes of 32 patients, mean age of about 65, and 14 patients have had bilateral surgeries. And the mean follow-up was 15 days. Since it's our initial results, it's only 15 days. You see that the patient's best vision at distance, about 6/9, 100% of them have it, and 6/6, about 95% of our patients do have great 6/6 vision. If you're talking about the spherical equivalent, 84% of them fall within ±0.5. Because it's a proven platform, you know your biometry is bang on. And that's why you have very predictable results. Coming to the intermediate vision, 66 centimeters is what is usually checked, and we use it, the ETDRS charts. Most of the patients are 6/7.5 and 6/9 at 66, and this is where your intermediate vision comes in. 40 centimeters is nothing, but your reading 80 is, I would say, a little bit more than your intermediate, but nobody has an arm span of 80 centimeters to use a mobile phone. You use it mainly at 60 centimeters, 66 centimeters. This is something which is very interesting. This is the uncorrected intermediate visual acuity. And you can see that most of the patients had really great visual acuity. At 92% of your patients had 6/9 vision acuity, and that's really great. This is at 66 centimeters. Coming to the reading speeds, which sir has already told you about, the SRD, anything above 120 is very great, 150 is excellent, and at 66 centimeters, 170 words per minute, and that's just magnifies how good these lenses are at intermediate vision. It's not that you don't get vision at 40 and 80, you do get, but the main work is at basically around 66 centimeters, where it induces about 1.5 diopter. And that is shown over here in your defocus curve, where it works over 1.5 diopter, you get a good 6/7.5 vision, and that is why the patients do so well, without any compromise in glare and halos. So most of the patients are really, really happy about the intermediate vision. They were told that near vision, yes, they need. And many of the patients we asked, how many of you would recommend these lenses? And about 94 to 95% of them said, yes, we will recommend. So just to conclude, when you have to have a balancing act between good vision without the compromise of quality of vision and spectacle independence, definitely enhanced monofocals play a very, very important role because there are no glare and halos over here. And IMPRESS, which we have done the study, has proved that intermediate vision and distant vision patients are spectacle independent. So as to conclude, that definitely try these lenses and they really help out. Thank you very much. Thank you. Yeah, we have one question from the audience. Yes, please tell me, sir. Yes. Yes, you can do a micro monovision. Keep about 0.75 of difference between the two. And patients, it's like how you do, you know, earlier when we used to get multifocal, we used to get different ads of multifocals. You could put 4 in one and 3.25 in the other. You can do a micro monovision, and that just gives the focus more for near in the non-dominant eye. So that is possible and definitely there. You can do it. But remember, when you do a micro monovision or anything, depth perception, especially make it very clear that if you're threading a needle or doing some fine painting or jewelry designing, that will get compromised. Make it very clear to your patients. Then you have the trifocal geometric for that. That's affected, yes. I'll give the vote of thanks also back to back so that we save on time. Yeah. So there's a fine line, Dr. Sri Ganesh said that where you have blended vision and when you have actually mono vision. So that should be taken care of, and that your patient should be told. Without further ado, we are running short of time. I know you all are late. I will give the vote of thanks outright. So today has been a cocktail of incredible experiences packaged neatly in the form of a CME. An event of such magnitude can only come to fruit with the concerted efforts of a large group of people. Firstly, I would like to thank our CMD, Dr. Sri Ganesh, sir. His vision enables us to conduct such events with resounding success, and I'm sure with his support, we shall continue to do so. The stellar faculty performing live surgeries, our speakers, I express my thanks to them for lending their precious skill and their time. There are many people to thank. Countless hours have been spent by the organizing team to ensure flawless execution of the program. The IT team has been crucial right from the setting up the equipment to the perfect relay of live surgeries. The business development team for the smooth registrations and helping with the faculty arrangements. The administrative staff, the HR team, because working backstage is equally important and challenging as working on stage. The counselors, the OT staff, ensuring that our patients undergoing live surgeries are treated with the highest level of care and professionalism. Our biomedical team, who has lent us their expertise on this bright Sunday. Special thanks to our medical superintendent, our consultants, fellows, and DNBs, all who have worked tirelessly over these few days. I would like to mention over here a special thank you to Dr. Supriya, my co-organizing secretary, who has worked tirelessly from the inception of this program, but couldn't be here due to health reasons. But her hard work has paid off today. Also, all the support staff and anyone else I missed mentioning specifically, it's only from the mind and not from the heart. I have utmost respect for your contribution that today's event could be a grand success. A big cheer to our sponsors today, Hoya Surgical, Optics, whose constant innovation has helped us ophthalmologists to push the boundaries in the realms of surgery. A supporting sponsor, Sun Pharma, a name synonymous with quality, trust and experience. And lastly, and not the least, I would like to thank our audience for all the efforts they have made, keeping you eager learners in mind. And I hope today you are a bit closer in mastering premium IOL surgery. And thank you very much, and I wish you all a very, very happy Sunday.
Thank you, Dr. Savio, and I'll just like to first of all thank Dr. Rishikesh and Dr. Janki for wonderful program organizing. And I would like to thank Dr. Sheetal. She is not well as far as a lot of pain, and she has done a wonderful surgery and also the presentation. She just traveled today, and the entire organizing committee. I think that we cannot be more prouder than associating with Dr. Sri Ganesh and the team in organizing such program. Thank you very much.
Lastly, I would just like to invite Dr. Savita ma'am to come and felicitate Dr. Savio. With that, we hereby conclude today's incredible journey, which we have experienced, and this encourages us to be a part of further academic associations. We have organized lunch on the next building basement. Kindly join us there. I would like to call upon the Hoya sponsors on stage. And I would request Dr. Savita ma'am to felicitate them for their wonderful efforts and contributions. I would now like to call upon the Sun Pharma team and would request Dr. Savitarun to felicitate them. Thank you, Sun Pharma, for your wonderful contribution.